Welcome to the Deep Dive, the show where we dedicate ourselves to truly mastering complex topics. We cut through the noise, diving headfirst into the most intricate details, aiming to give you a level of understanding that makes you feel genuinely well-informed, almost like an elite professional in the field. Today we're dissecting an organ that is often overlooked, residing quietly within us, yet it's undeniably one of the most vital, the small intestine. Did you know that this seemingly simple tube is, in fact, one of the most complex, diverse, and even immune-active organs in your entire body?
That's a profound observation, and it's absolutely at the heart of our discussion today. While its fundamental role in digestion is universally recognized, the small intestine's astonishing complexity, particularly its extensive immunological and endocrine functions, is truly a marvel. To genuinely master this subject, as you, our listener, intend, a thorough understanding of this organ is not just beneficial, it's absolutely essential. This is especially true because, despite the relative infrequency of its diseases compared to other GI organs, they present particularly significant diagnostic and therapeutic puzzles for clinicians. For this deep dive, we're drawing our insights from Schwartz's Principles of Surgery, a foundational and highly authoritative text in the medical field. This ensures that the information we explore is both deep in its detail and unwavering in its reliability.
Our mission today is explicitly defined. We're going to meticulously unpack every critical insight contained within this authoritative text. Our goal is to provide you, our dedicated listener, with those illuminating aha moments that arise not just from knowing facts, but from truly understanding the intricate mechanisms and broader implications. This isn't about just skimming the surface. It's about delving deep enough that you'll approach this topic with the same discerning insight as an elite professional. We're going to cover everything that makes this incredible organ tick, from its tiniest, most fundamental cells to the major, most challenging conditions that can profoundly affect it. So let's begin our deep dive into the small intestine.
The small intestine, a marvel of design and function. Introductory comments. More than just a tube.
Let's start by challenging a very common yet profound misconception. When most of us visualize the small intestine, we probably picture it primarily as a simple conduit, a tube through which digested food merely passes. Perhaps we acknowledge its role in nutrient absorption, but the truth is, it is so much more than just a digestive tube. While it absolutely stands as the principal site of nutrient digestion and absorption, this organ simultaneously fulfills another, equally, if not more, crucial dual role. It harbors the body's largest reservoir of immunologically active and hormone-producing cells. That is an absolutely astounding claim for an organ we'd so often simplify to just digestion. Wouldn't you agree?
It absolutely is, and it truly redefines our understanding of its significance within the human body. This expansive dual functionality is precisely why the small intestine is now often conceptualized not just as a digestive organ, but as the largest organ of the immune and endocrine systems. This concept might indeed surprise many, but when you delve into why it possesses such remarkable diversity of action, its design brilliance becomes startlingly clear. This multifaceted capability is fundamentally attributable to its unique anatomical features. A massive surface area that belies its tubular form, an astonishing diversity of cell types, each specialized for distinct tasks, and a highly complex neural network that intricately coordinates all these functions. These inherent design marvels are what empower it to fulfill roles that extend far beyond mere nutrient processing, placing it at the very heart of systemic health.
And despite this immense size and truly incredible importance, it presents a fascinating paradox, one that can be quite frustrating for medical professionals. Diseases affecting this organ are remarkably relatively infrequent when compared to other parts of the gastrointestinal tract, yet they consistently pose diagnostic and therapeutic challenges. Our source material points out these limitations quite explicitly. For instance, even with the introduction of novel imaging techniques such as capsule endoscopy and double balloon endoscopy, diagnostic tests lack sufficient ability to reliably assess the small bowel. What's more, there are few high-quality controlled data on the efficacy of surgical therapies for small bowel diseases. This means that even with all our advanced medical technology, figuring out precisely what's wrong and determining the most effective way to fix it is not always straightforward.
Precisely. This diagnostic and therapeutic conundrum strongly underscores the core takeaway embedded within our authoritative source material. It emphasizes that sound clinical judgment and a thorough understanding of anatomy, physiology, and pathophysiology remain essential to the care of patients with suspected small bowel disorders. For you, the listener, striving for mastery in this subject, this isn't merely an academic exercise. It's about cultivating the kind of deep, foundational understanding that is genuinely indispensable for anyone serious about comprehending the profound intricacies of human health, particularly as they pertain to this vital yet often enigmatic organ. Gross anatomy, laying the foundation.
Okay, let's begin our deep dive into the foundational architecture of the small intestine, starting with what you'd observe with the naked eye during a macroscopic examination. At its most basic, the small intestine is a tubular structure that extends from the pylorus, that crucial sphincter regulating the passage of food from the stomach to the cecum, which marks the very beginning of the large intestine. The sheer length of this tube is quite remarkable when considering its internal positioning. In living individuals, its estimated length ranges from 4 to 6 meters. To put that into perspective, imagine a substantial garden hose or very long piece of rope, all intricately coiled and organized within your abdominal cavity. It's quite a feat of biological engineering.
Indeed, that extensive length is then cleverly segmented into 3 distinct portions that lie in a precise series, each with its unique characteristics. The first and most proximal is the duodenum. This segment immediately follows the pylorus of the stomach and lies adjacent to the head and inferior border of the pancreas. What's unique about the duodenum is its retroperitoneal location, meaning it's fixed behind the abdominal lining, unlike much of the rest of the small intestine. Its boundaries are precisely defined. It starts at the pylorus and transitions into the jejunum at a critical anatomical landmark known as the ligament of Treitz.
Right, the ligament of Treitz, that's key.
Exactly. Following the duodenum are the jejunum and ileum. These 2 segments predominantly reside within the peritoneal cavity, which allows for some mobility, but they are still tethered to the posterior abdominal wall by a broad, fan-shaped fold of peritoneum called the mesentery. There's no distinct anatomical landmark that separates the jejunum from the ileum. Instead, their demarcation is arbitrary. The proximal 40% of the jejunal segment is arbitrarily defined as the jejunum, and the distal 60% as the ileum. Finally, the ileum concludes its journey, transitioning into the cecum, the beginning of the large intestine, via the ileocecal valve, another important sphincter.
Now, here's where it gets really interesting when you move beyond the external form and peer inside the small intestine. On gross inspection of the internal lining, you'd immediately notice these fascinating transverse folds of mucosa. These are known formally as plicae circulares, or more commonly, valvulae conniventes. They're not just aesthetically intriguing, they hold significant diagnostic value. Importantly, they are visible radiographically and help in the distinction between small intestine and colon, which does not contain them, on abdominal radiographs. This is a crucial visual clue for clinicians. Furthermore, these folds are not uniformly distributed. They are more prominent in the proximal intestine, gradually diminishing in size and number as you move towards the ileum. This offers another subtle hint as to your location within the small bowel.
And those internal folds aren't the only distinguishing features when we compare the segments. If you were to visually compare the jejunum and the ileum, the jejunum typically presents with a larger circumference, indicating a wider lumen and a thicker wall. Its mesentery is often less fatty, and it has longer vasa recta, which are the straight arteries directly supplying the intestinal wall. In contrast, a key distinguishing feature prominent upon gross examination of the ileum are specialized aggregates of lymphoid follicles, specifically known as Pear's patches. These patches, located predominantly in the ileum, represent a significant component of the gut's immune system, a critical function we will meticulously explore in a dedicated segment later in our deep dive.
Beyond the tubular structure itself and its internal folds, the small intestine is fundamentally supported by an intricate and meticulously choreographed network of blood vessels and nerves. Let's trace its vital blood supply. The duodenum, due to its unique embryological origins and anatomical position, receives a dual arterial blood supply, drawing from branches of both the celiac artery and the superior mesenteric artery. The rest of the small intestine, including the distal duodenum, the entire jejunum, and the ileum, relies exclusively on the superior mesenteric artery for its primary blood supply. All of this arterial blood, once utilized, then drains via the superior mesenteric vein.
Right. And the lymphatic drainage is equally well organized, flowing through a system of lymphatic vessels that course precisely parallel to their corresponding arteries. These vessels drain through a series of mesenteric lymph nodes, eventually converging into the cisterna chyli, then traveling through the thoracic duct, and ultimately emptying into the left subclavian vein, returning the lymph to the systemic circulation.
As for its innervation, the parasympathetic supply, which generally promotes activity, is derived from the vagus nerve, while the sympathetic innervation, which typically inhibits activity, originates from the splanchnic nerves. It truly is a beautifully orchestrated and incredibly complex system, reflecting millions of years of evolutionary refinement. Histology, delving into the microscopic world.
Moving our focus from the macroscopic architecture to the minute, intricate details visible only under a microscope, we delve into the histology of the small intestine wall. Like many other hollow organs in the body, its wall is fundamentally composed of 4 distinct layers, each meticulously organized and performing specialized roles. From the outermost layer to the innermost, these are the serosa, which forms its external covering, the muscularis propria, responsible for its movement, the submucosa, a supporting layer, and finally the mucosa, which is the innermost lining in direct contact with the intestinal contents. Understanding each layer's contribution is essential to grasping the organ's full functionality.
Let's truly zoom in on that innermost layer, the mucosa, because this is where the vast majority of the small intestine's critical work actually takes place. The mucosa itself is not a simple single layer, but rather a sophisticated composition of 3 distinct sublayers. First, there's the epithelium, which is the outermost surface, directly exposed to the intestinal lumen. This is the interface, the very boundary, across which all interactions with the ingested food occur. Beneath the epithelium lies the lamina propria, a crucial layer of loose connective tissue that provides structural support and houses various cells, including immune cells. Finally, separating the mucosa from the underlying submucosa is the muscularis mucosae, a thin sheet of smooth muscle. That epithelium at the forefront is profoundly important because it truly is the surface through which absorption from and secretion into the lumen occurs. This is where the profound magic of nutrient uptake and the subtle dance of secretions actually happens.
And the organization of that mucosal layer is truly a marvel of biological design, specifically structured to maximize efficiency. Its surface is extensively folded into distinct, highly organized structures called villi and crypts, the latter also known as crypts of Lieberkühn. The villi are exquisite, finger-like projections of epithelium and underlying lamina propria that contain blood and lymphatic vessels known as lacteals that extend into the intestinal lumen. These villi are not merely decorative. Their presence dramatically increases the functional surface area available for absorption, turning a simple tube into an incredibly efficient processing plant.
Incredible.
Critically, within this dynamic environment, intestinal epithelial cellular proliferation, meaning the generation of new cells, is confined to the crypts. Each individual crypt is a bustling, self-renewing mini-factory teeming with 250 to 300 cells, all originating from multipotent stem cells located at or near the crypt space. These stem cells are the ultimate progenitors, ensuring the continuous renewal of this vital lining.
Now, here's where it gets really interesting and reveals the incredible dynamism and resilience engineered into this organ at a cellular level. Our understanding of these crypt-based stem cells has expanded dramatically with cutting-edge research. It turns out there aren't just one type, but 2 subgroups of intestinal stem cells with specific cell markers. This dual system reflects a sophisticated strategy for both routine maintenance and rapid repair. We have the BM1 positive cells, which are typically quiescent, meaning they're mostly dormant, and interestingly, they're radiation-resistant cells that are induced by injury. Think of them as a robust emergency backup crew. Then there are the LGR5 positive cells, which are more active in facilitating homeostatic or everyday regeneration, but they also contribute to injury-induced regeneration. Crucially, unlike the BM1 positive cells, they are radiation sensitive. This dual system ensures both steady day-to-day renewal and a robust capacity for recovery from significant damage, even specific types of trauma like radiation exposure. It's an incredible testament to the body's built-in resilience system.
From these remarkable stem cells at the crypt base, various specialized cell types embark on distinct differentiation pathways, ultimately giving rise to 4 primary lineages: enterocytes and goblet, enteroendocrine, and panath cells. With the notable exception of panath cells, which remain strategically positioned at the base of the crypt, all other lineages complete their terminal differentiation as they undertake a continuous upward migration from each crypt to adjacent villi, moving steadily towards the villus tip.
And this cellular journey from the crypt to the villus tip is incredibly fast and efficient. The journey from the crypt to the villus tip is completed in 2 to 5 days and terminates with cells being removed by apoptosis and/or exfoliation. Apoptosis is programmed cell death, while exfoliation means they simply shed off. This rapid, continuous cycle means that the small intestinal epithelium undergoes continuous renewal, making it one of the body's most dynamic tissues. It's constantly rebuilding itself. But while this high cellular turnover rate profoundly contributes to the mucosa's resiliency and ability to repair daily wear and tear, it also carries a significant consequence. It makes the intestine uniquely susceptible to certain forms of injury, such as that induced by radiation and chemotherapy. This explains why cancer patients often experience such profound gastrointestinal side effects during their treatments, as these therapies target rapidly dividing cells.
To truly appreciate the small intestine's functional elegance, let's detail the specific functions of these crucial epithelial cell types. Enterocytes are the undisputed workhorses. They are the predominant absorptive cell of the intestinal epithelium. Their efficiency is amplified by their apical lumen-facing cell membrane, which is densely packed with specialized digestive enzymes, complex transporter mechanisms, and countless microvilli. These microvilli, which are tiny, finger-like projections themselves, are estimated to increase the absorptive surface area of the small intestine by an astonishing 40-fold. This monumental increase is key to nutrient uptake.
40-fold, just from the microvilli.
Exactly. Goblet cells derive their name from their characteristic shape. They are responsible for producing mucin, the primary protein component of the thick, protective mucus layer that lines the intestinal lumen. This mucin is believed to play a vital role in mucosal defense against pathogens, forming a crucial physical and chemical barrier. Enteroendocrine cells are discretely dispersed among the other epithelial cells. Their defining feature is their secretory granules containing regulatory agents. These cells are the very heart of the small intestine's role as a major hormone-producing organ, a sophisticated function we will meticulously discuss in its own dedicated segment, revealing their widespread impact on the body. Paneth cells, as mentioned, are uniquely and strategically located at the very base of the crypts. They contain secretory granules containing growth factors, digestive enzymes, and antimicrobial peptides. Through the controlled secretion of these diverse substances, Paneth cells play a fundamental role in actively controlling the host microinteraction and influencing the intestinal microbiome, essentially shaping the environment for the vast bacterial communities within our gut. Briefly mention the additional immune components, M cells, and intraepithelial lymphocytes.
Moving beyond the mucosa, let's briefly describe the remaining layers of the small intestinal wall, each contributing to its overall integrity and function. The next layer is the submucosa. This consists of dense connective tissue that provides structural support, and within it lies a heterogeneous population of cells, including leukocytes, which are immune cells, and fibroblasts, which are involved in tissue repair. Crucially, the submucosa is also rich with an extensive network of vascular and lymphatic vessels, vital for blood and lymph flow, as well as nerve fibers and ganglion cells of the submucosal Meissner's plexus. This plexus is a key component of the enteric nervous system, often called the second brain, influencing localized secretion and blood flow.
Moving outwards, we encounter the muscularis propria. This layer is responsible for the powerful rhythmic contractions of the gut, and it's composed of two distinct sublayers of smooth muscle fibers. An outer longitudinally oriented layer, which shortens the bowel, and an inner circularly oriented layer, which narrows the lumen. At the interface of these two muscle layers, you find more ganglion cells of the myenteric Auerbach's plexus, another crucial part of the enteric nervous system that primarily coordinates motility.
And finally, the outermost layer is the serosa. This consists of a single layer of mesothelial cells and is a component of the visceral peritoneum, essentially serving as the smooth, protective outer covering of the bowel, allowing it to move freely within the abdominal cavity without friction. Development: how the small intestine takes shape.
To truly grasp the small intestine's complex adult form and function, we must journey all the way back to the very earliest stages of embryonic development. The rudimentary precursor of the small intestine is the embryonic gut tube, which begins to form from the endoderm during the remarkably rapid period of the 4th week of gestation. This early gut tube isn't uniform. It's initially subdivided into 3 distinct regions: the foregut, the midgut, and the hindgut. It's interesting to note that while the majority of the small intestine, specifically the jejunum and ileum, is derived from the midgut, the duodenum has a somewhat different origin, being primarily a foregut structure. This distinction is important for understanding certain developmental anomalies and vascular supplies.
What's truly fascinating during these nascent stages is the initial connection of this embryonic gut tube to the yolk sac via a narrow passage called the vitelline duct. This duct plays a role in early nutrient transfer. Normally, this vitelline duct progressively narrows by the 6th week of gestation and then undergoes complete obliteration by the end of gestation, meaning it completely disappears. However, when there's incomplete obliteration of this duct, it leads to a spectrum of clinically significant defects, collectively known as Meckel's diverticuli, which is a persistent pouch-like remnant of the yolk sac. This is the most common congenital anomaly of the GI tract. Other related abnormalities that can arise from this incomplete closure include an omphalmocenteric fistula, where the gut remains directly open to the umbilical region, an enterocyst, which is a fluid-filled cyst of vitelline duct origin, or a fibrous band connecting the intestine to the umbilicus, which can cause later problems.
Alongside the gut tube's development, during that same formative fourth week of gestation, the mesoderm, one of the primary germ layers, undergoes a crucial splitting process. The portion of the mesoderm that adheres closely to the endoderm of the gut tube forms the visceral peritoneum, which will eventually envelop and support the abdominal organs. Concurrently, the portion of the mesoderm that adheres to the ectoderm, the outer germ layer, forms the parietal peritoneum, which lines the inner surface of the abdominal cavity. This intricate mesodermal division effectively creates a spacious internal cavity known as the coulommic cavity. This cavity is the direct precursor to the peritoneal cavity, the vital space that will ultimately house many of our major abdominal organs, including most of the small intestine.
And then, at approximately the 5th week of gestation, something truly remarkable and temporary occurs during the small intestine's rapid growth. The developing bowel begins to lengthen at a pace greater than that which can be accommodated by the developing abdominal cavity. This incredible growth spurt forces a temporary physiological herniation of the developing bowel outside the confines of the coulommic cavity. This process, known as extracoulommic herniation, is a natural and necessary step in its expansion, allowing the bowel to achieve its eventual substantial length before it can fit back into the abdominal space.
This period of extracoulommic herniation is then followed by a meticulously choreographed retraction and rotation of the bowel. The rapidly lengthening bowel gradually retracts back into the abdominal cavity during the 10th week of gestation. As it does, the duodenum, due to its initial position, becomes a retroperitoneal structure, effectively fixing its position against the posterior abdominal wall. Coincident with both this extrusion and retraction, the entire bowel undergoes a highly complex and precise 270 degrees counterclockwise rotation relative to the posterior abdominal wall. This intricate, almost balletic choreography of rotation is not arbitrary. It fundamentally accounts for the usual locations of the cecum in the right lower quadrant and the duodenojejunal junction to the left of midline. This highly specific positioning, visually represented in anatomical diagrams, is absolutely essential for the proper functional organization of our adult intestines.
Even the intricate vascular and neural systems that supply the small intestine have distinct and fascinating embryonic origins. The celiac and superior mesenteric arteries and veins, which, as we discussed earlier, are the main conduits for blood supply to the small intestine, are derived from the vitelline vascular system. This vitelline system itself originates from a network of blood vessels formed within the splanchnopleural mesoderm during the 3rd week of gestation. Similarly, the complex neural components of the small intestine, the very neurons that orchestrate its sophisticated movements and secretions, are derived from neural crest cells. These remarkable cells begin their migration away from the neural tube during the 3rd week of gestation, and then meticulously spread throughout the entire developing bowel, forming the intricate enteric nervous system.
Another crucial, albeit temporary, developmental event occurs during the 6th week of gestation. At this point, the lumen of the developing bowel actually becomes obliterated as bowel epithelial proliferation accelerates. It's as if the tube temporarily fills itself in completely with cells. Then, in a process vital for forming the functional lumen, vacuoles form within the bowel substance during the subsequent weeks and coalesce to form the intestinal lumen by the 9th week of gestation. This process is known as recanalization. Errors in this meticulous recanalization process can indeed account for certain birth defects, such as intestinal webs and stenoses, which are partial narrowings of the lumen. However, it's a critical distinction to note that most intestinal atregias, which are complete blockages of the lumen, are believed to be related to ischemic episodes occurring after organogenesis has been completed rather than to errors in recanalization. This means most complete blockages are due to a loss of blood supply later in development, not a failure of the initial tube formation.
So by the 9th week of gestation, the intestinal epithelium begins its final stages of maturation, developing its highly specialized intestine-specific features such as cryptvillous architecture, those incredible finger-like projections, and the regenerating bases that we explored earlier. And remarkably, the entire complex process of organogenesis is complete by approximately the 12th week of gestation. This means that within the first trimester of human development, this incredibly complex, multifunctional organ, equipped with all its specialized structures and systems, is fully formed and ready to begin its life's profound work of digestion, absorption, and intricate internal communication.
The intricate workings physiology, digestion and absorption, the master of nutrients.
Now we arrive at what most people instinctively recognize as the primary function of the small intestine, the profound processes of digestion and absorption. At its very essence, the intestinal epithelium is the interface through which absorption and secretion occur. This biological barrier is exceptionally designed for its complex tasks. Its epithelial cells exhibit a crucial polarity, featuring distinct apical or lumen-facing cell membranes and basolateral or blood-facing cell membranes. These two regions are precisely demarcated by intercellular tight junctions, which meticulously control what passes between cells. Furthermore, there's an asymmetric distribution of specialized transmembrane transporter mechanisms that ultimately promote vectorial transport of solutes across the epithelium, meaning nutrients are efficiently moved in one highly directed path, from the gut lumen, across the cells, and into the bloodstream. It's a system built for one-way efficiency.
To truly master how those vital nutrients traverse this barrier, it's fundamental to differentiate between the two primary modes of solute transport: active transport and passive transport. Active transport is the energy-dependent net transfer of solutes, meaning it requires cellular energy and it can move substances in the absence of or even against an electrochemical gradient. This type of transport occurs exclusively through transcellular pathways, where the solute passes directly through the cell itself. In contrast, passive transport involves the movement of solutes through diffusion or convection and is driven by existing electrochemical gradients. This means substances move from an area of higher concentration or pressure to an area of lower concentration. Passive transport can occur through either transcellular pathways or paracellular pathways, where solutes move between the cells directly through the tight junctions. Transcellular transport, whether active or passive, fundamentally relies on specialized membrane proteins, such as channels, carriers, and pumps, each meticulously designed for specific substances. What's particularly fascinating about the paracellular pathway is that recent understanding reveals it's far from a simple, unregulated leak. It is now recognized as substrate-specific, dynamic, and subject to regulation by specific tight junction proteins, indicating a highly controlled passage system. Water and electrolyte absorption and secretion.
Let's consider the sheer volume of fluid this remarkable organ processes daily. It's truly astounding, and a testament to its efficiency. An incredible 8 to 9 liters of fluid enter the small intestine daily. What's particularly striking is that the vast majority of this volume isn't from what we consume. Instead, it consists predominantly of our body's own digestive contributions: salivary, gastric, biliary, pancreatic, and its own intestinal secretions. Then, with an almost unbelievable efficiency, under normal conditions, the small intestine absorbs over 80% of this fluid, leaving approximately 1.5 liters that enters the colon. This massive fluid flux, visually represented in anatomical diagrams, underscores the meticulous regulation of water and electrolyte homeostasis within the small intestine. You can immediately grasp how derangements in water and electrolyte homeostasis, characteristic of many of the disorders discussed in this chapter, play an important role in contributing to their associated clinical features, leading to severe clinical consequences like profound dehydration or electrolyte imbalances.
Indeed, the transport of water in gut epithelia, critical for maintaining the body's fluid balance, occurs through two primary pathways: the paracellular route, where water moves through the spaces between the cells, and the transcellular route, where it passes directly through the apical and basolateral cell membranes. The bulk of water transport, however, occurs through this transcellular pathway. While the precise molecular mechanisms governing this transcellular movement are still under active investigation, they are known to involve passive diffusion directly through the cell's phospholipid bilayer, co-transport mechanisms where water follows the movement of other ions and nutrients, or diffusion through specialized water channels called aquaporins. Interestingly, despite the discovery of many types of aquaporins, their overall contribution to intestinal water absorption appears to be relatively minor when compared to other, more dominant mechanisms driven by solute transport.
So, how does the body so efficiently draw all that water from the intestinal lumen into the bloodstream? A significant part of this process fundamentally hinges on the active absorption of sodium ions. The prevailing mechanistic model for intestinal epithelial sodium absorption, a cornerstone of fluid regulation, is beautifully illustrated in advanced physiological diagrams. It meticulously details the action of the Na plus K plus ATPase enzyme, a critical ion pump strategically located in the basolateral membrane of the enterocytes. This pump actively exchanges 3 intracellular Na plus for every 2 extracellular K plus in an energy-dependent process. This continuous ATP-driven outward pumping of sodium is what meticulously generates the electrochemical gradient, effectively creating a powerful localized vacuum that fundamentally drives sodium from the intestinal lumen into the intracyte cytoplasm. Sodium then traverses the apical membrane through several distinct transporter mechanisms, including nutrient-coupled sodium transport, exemplified by the crucial sodium-glucose cotransporter 1, SGLT1, as well as specialized sodium channels and sodium-hydrogen exchangers, NHEs. Once inside the cell, the absorbed sodium is then actively extruded back into the bloodstream by that same Na plus K plus ATPase, completing the vectorial transport.
It's important to recognize that similar mechanistic models that account for the transport of other common ions such as K plus and HCO3 also exist, each with their own specialized transporters and regulatory mechanisms. Furthermore, substantial heterogeneity with respect to both crypt-villus and craniocaudal axes exists for intestinal epithelial transport mechanisms. This means the specific transporters and their activity levels vary depending on whether you're looking at the crypts versus the villi or the duodenum versus the ileum. This pattern is entirely consistent with the functional model where absorptive function resides primarily in the villus and secretory function in the crypt. Beyond these intrinsic cellular mechanisms, both intestinal absorption and secretion are dynamically modulated under a variety of physiologic and pathophysiologic conditions by a wide array of hormonal, neural, and immune regulatory mediators. For instance, as summarized in detailed physiological tables, agents like aldosterone and somatostatin are known to stimulate absorption or inhibit secretion, while others, such as secretin and prostaglandins, predominantly stimulate secretion or inhibit absorption, showcasing an intricate and responsive system. Carbohydrate digestion and absorption.
Let's shift our focus to carbohydrates, which represent a significant cornerstone of our dietary energy. They account for approximately 45% of energy consumption in the average Western diet. Of this substantial portion, about half is in the form of starch, derived primarily from cereals and various plant sources. Beyond starch, our diets include other major carbohydrate sources such as fructose, glucose, and sucrose, which are naturally found in vegetables and fruits or purified from sources like sugarcane and beets. It's also important to remember the variety of sugars present in processed foods, including various oligosaccharides and polysaccharides, all contributing to our overall carbohydrate intake.
The complex process of carbohydrate digestion begins, surprisingly, in the mouth with the action of salivary amylase. However, it's crucial to understand that pancreatic amylase is the major enzyme of starch digestion, performing the bulk of the initial breakdown in the small intestine. The products of this initial intraluminal digestion, which include oligosaccharides, maltodextrose, maltose, and alpha-limit dextrins, as well as the principal dietary disaccharides, sucrose and lactose, are unable to undergo absorption in this form. They must first undergo a final critical step of hydrolytic cleavage into their constituent monosaccharides, catalyzed by specific brush border membrane hydrolases, which are expressed most abundantly in the villi of the duodenum and jejunum. Identify the 3 major monosaccharides that are the terminal products: glucose, galactose, and fructose.
So, once these complex carbohydrates have been meticulously broken down into their fundamental monosaccharide units, glucose, galactose, and fructose, how do they actually cross that critical epithelial barrier and enter our bloodstream? Under normal physiological conditions, the majority of these monosaccharides are efficiently absorbed via the transcellular route. For both glucose and galactose, their journey across the enterocyte's brush border membrane is facilitated by the intestinal Na plus glucose cotransporter, SGLT1. This is a classic example of secondary active transport, cleverly utilizing the sodium gradient that we discussed earlier to power the uptake of these sugars. Fructose, on the other hand, employs a different mechanism. It's transported across the brush border membrane by facilitated diffusion via GLUT5. Once all 3 monosaccharides have successfully entered the enterocyte, they are then extruded through the basolateral membrane by facilitated diffusion using GLUT2 and 5 transporters, finally diffusing into the nearby venules and ultimately entering the portal venous system, heading directly to the liver for further processing.
What's truly fascinating here, and serves as an excellent illustration of how our deep understanding of basic physiology can lead directly to groundbreaking clinical applications, is the compelling evidence of overexpression of hexose transporters, specifically SGLT1, in disease states such as diabetes. This critical insight has paved the way for significant therapeutic advancements. Inhibitors of the glucose transporter are being investigated as a novel therapy for disease states such as diabetes and obesity. In fact, this connection has become so robust that recent consensus statements have officially recognized the small bowel as a therapeutic target for treatment of diabetes. This exemplifies how meticulously dissecting the intricate physiology of the gut can yield entirely unexpected and highly impactful therapeutic breakthroughs, transforming how we approach complex systemic diseases. Protein digestion and absorption.
Let's shift our focus to proteins, another essential macronutrient. They typically constitute 10% to 15% of energy consumption in the average Western diet. However, it's a crucial point to understand that our bodies don't just rely on dietary protein. Approximately one-half of the protein load that enters the small intestine is derived from endogenous sources, meaning proteins that our own body produces and then redigests. These include proteins from salivary and gastrointestinal secretions, as well as those from desquamated or shed intestinal epithelial cells. So our bodies are remarkably efficient at recycling and recovering valuable amino acid building blocks from within the digestive tract itself.
The complex process of protein digestion actually begins quite early in the stomach with the action of pepsins, though this step is not an essential step, as patients without stomachs can still digest proteins. Digestion continues vigorously in the duodenum with the actions of a variety of pancreatic peptidases, which are secreted as inactive proenzymes, contrasting with amylase and lipase. Explain the crucial activation step for pancreatic peptidases. In response to the presence of bile acids, enterokinase is liberated from the intestinal brush border membrane to catalyze the conversion of trypsinogen to active trypsin. Trypsin in turn activates itself and other proteases. The final products of intraluminal protein digestion consist of neutral and basic amino acids and peptides, 2 to 6 amino acids in length.
Beyond that initial extensive intraluminal digestion in the lumen, the breakdown of proteins continues even further, with additional digestion occurring through the actions of peptidases that exist in the enterocyte brush border and cytoplasm. So it's a multi-stage, highly efficient process that ensures virtually all proteins are reduced to absorbable units. As for absorption, both single amino acids and diuretripeptides are absorbed via specific membrane-bound transporters. This means there are dedicated proteins on the enterocyte membrane that recognize and take up these specific building blocks. Once absorbed into the enterocytes, these amino acids and peptides then enter the portal venous circulation, heading directly to the liver for subsequent metabolic processing. And here's a truly unique and metabolically significant detail. Of all the amino acids, glutamine appears to be a unique major source of energy for enterocytes, with active uptake mechanisms present on both the apical and basolateral cell membranes. This highlights its critical role in maintaining intestinal health and function, fat digestion and absorption. Now let's explore the digestion and absorption of fats, which typically account for approximately 40% of the average Western diet. The vast majority of this dietary fat, over 95%, is in the form of long-chain triglycerides, with the remainder including phospholipids, fatty acids, cholesterol, and fat-soluble vitamins. Note that over 94% of the ingested fats are absorbed in the proximal jejunum.
The initial challenge: fats are water insoluble. Explain solubilization by mastication and antral peristalsis into an emulsion. Lipolysis initiated by gastric lipase, but its principal site is the proximal intestine, where pancreatic lipase is the catalyst.
Describe the vital role of bile acids. Act as detergents that help in solubilization of the lipolysis by forming mixed micelles. Explain mixed micelles as polymolecular aggregates with a hydrophobic core of fat and a hydrophilic surface that act as shuttles.
Explain the enterohepatic circulation. Bile salts remain in the bowel lumen and travel to the terminal ileum, where they are actively resorbed into the portal circulation and re-secreted into bile. Introduce the unstirred water layer as a site of lipid dissociation from micelles.
Detail the absorption process. Most lipids in proximal jejunum, bile salts in distal ileum active. Introduce fatty acid binding proteins, FABP, and the active but uncharacterized process for cholesterol. Inside enterocytes, triglycerides are resynthesized and incorporated into chylomicrons that are secreted into the intestinal lymphatics and ultimately enter the thoracic duct.
Crucially, differentiate short and medium chain triglycerides. More hydrophilic and are absorbed without undergoing intraluminal hydrolysis, micellar solubilization, mucosal reesterification, and chylomicron formation. They directly enter portal venous circulation. Connect this to practical application. This information provides the rationale for administering nutritional supplements containing medium-chain triglycerides to patients with gastrointestinal diseases associated with impaired digestion and malabsorption of long-chain triglycerides, vitamin and mineral absorption.
Discuss vitamin B12, cobalamin malabsorption due to surgical manipulations.
Brilliant.
Walk through its complex journey, bound by saliva or protein, R protein hydrolyzed in duodenum. Cobalamin binds intrinsic factor, gastric parietal cell-derived. Complex reaches terminal ileum, specific receptors, enters enterocytes by translocation. Explain surgical implications, gastric resection, bypass, ileal resection.
Briefly list other water-soluble vitamins with carrier-mediated transport. Note fat-soluble vitamins, A, D, E, absorbed by passive diffusion, and vitamin K by both passive and carrier-mediated.
Calcium absorption, both transcellular, major in duodenum, mediated by calbindin, regulated by vitamin D, and paracellular. Highlight clinical relevance for surgical patients. Abnormal calcium levels are increasingly seen in surgical patients who have undergone a gastric bypass. Advise. Calcium citrate is a better formulation for supplemental therapy than calcium carbonate for low acid exposure.
Briefly mention iron and magnesium absorption via both routes and the divalent metal transporter capable of transporting multiple metal ions in the brush border. Barrier and immune function. The gut's hidden defenders.
Present the paradox. The small intestine efficiently absorbs nutrients, yet must discriminate between pathogens and harmless antigens and resist invasion.
Describe epithelial defenses, immunoglobulin A, IgA, mucins, and the relative impermeability of the brush border, plus antimicrobial peptides, such as defensins. Reveal the astounding fact. The intestinal component of the immune system, known as the gut-associated lymphoid tissue, GLT, contains over 70% of the body's immune cells.
Break down GOLT into inductive and effector sites. Inductive sites, Peyer's patches, macroscopic aggregates of B-cell follicles and T-cell areas, primarily distal ileum, mesenteric lymph nodes, isolated lymphoid follicles.
Describe the specialized microfold M cells overlying Peyer's patches, which transfer microbes to underlying professional antigen-presenting cells, APCs, such as dendritic cells. Also, dendritic cells may sample luminal antigens directly. Explain how APCs prime naive lymphocytes that differentiate and accumulate in the intestinal mucosa. Effector sites. Effector sites. EGA-producing plasma cells in lamina propria, producing IgA transported to lumen as a dimer for proteolysis resistance, helping improve effector sites. CD4 plus T cells in lamina propria. Effector sites. CD8 plus T cells preferentially migrate to epithelium, also in lamina propria, central to immune regulation with potent cytotoxic CTL activity.
Emphasize the crucial role of the microbiota. Increasingly recognize that the gastrointestinal tract is colonized with many bacteria that are essential for health.
Explain the delicate balance. Communication between the microbiota and the host defense allows for protective immune responses against pathogens while preventing adverse inflammatory responses to harmless commensal microbes, which could lead to chronic inflammatory disorders such as celiac disease and Crohn's disease. Motility, the rhythmic movements of digestion.
Describe the syncytia of myocytes in intestinal muscle layers. Detail how muscularis propria contractions create peristalsis, outer longitudinal for shortening, inner circular for narrowing. Differentiate from muscularis mucosa, which contributes to mucosal or villus motility, but not to peristalsis.
Outline the several distinctive patterns of muscularis propria activity observed. Ascending excitation and descending inhibition. Explain this fundamental reflex where contraction is proximal to a stimulus, food bolus, and relaxation is distal, even in the absence of any extrinsic innervation. Fed or postprandial pattern. Begins within 10 to 20 minutes of meal ingestion and abates 4 to 6 hours afterwards. Rhythmic segmentations or pressure waves. Traveling only short distances, hypothesized to assist in mixing intraluminal contents and in facilitating their contact with the absorptive mucosal surface. Fasting pattern or interdigestive motor cycle, IDMC. Detail its 3 phases. Phase 1 is characterized by motor quiescence, Phase 2 by seemingly disorganized pressure waves occurring at submaximal rates, and Phase 3 by sustained pressure waves occurring at maximal rates. The purpose. Hypothesized to expel residual debris and bacteria from the small intestine. Note its duration. The median duration of the IDMC ranges from 90 to 120 minutes. And complexity. At any given time, different portions of the small intestine can be in different phases.
Explain the regulatory mechanisms. Pacemakers intrinsic to the small intestine and external neurohumoral modulatory signals.
Pinpoint the interstitial cells of Cajal as pleomorphic mesenchymal cells that generate the electrical slow wave, basic electrical rhythm or pace setter potential, that plays a pacemaker role. Note the frequency variation, from 12 waves per minute in the duodenum to 7 waves per minute in the distal ileum. Emphasize that smooth muscle contraction occurs only when an electrical action potential, spike burst, is superimposed on the slow wave.
Discuss neural and hormonal regulation. The enteric motor system, ENS, providing both inhibitory and excitatory stimuli. Excitatory transmitters. Acetylcholine and substance P. Inhibitory transmitters. Nitric oxide, vasoactive intestinal peptide, and adenosine triphosphate. Sympathetic input, inhibitory to the ENS. Parasympathetic input, more complex, affects both types of ENS motor neurons, making effects more difficult to predict.
Yeah.
Endocrine function, the body's largest hormone factory.
Begin with a historical note. Endocrinology as a discipline was born with the discovery of a secretin, an intestinal regulatory peptide that was the first hormone to be identified.
Convey the incredible scale. The small intestine is the largest hormone-producing organ in the body, with over 30 peptide hormone genes expressed, producing over 100 distinct regulatory peptides due to processing. Also mention monoamines and eicosanoids.
Evolved the listener's understanding of gut hormones, no longer just from enteroendocrine cells released into systemic circulation. Now known that gut hormone genes are widely expressed throughout the body, not only in endocrine cells, but also in central and peripheral neurons. They act as general intercellular messengers with endocrine, paracrine, autocrine, or neurocrine effects.
Mention the notable homology patterns, classifying about 1/2 of the known regulatory peptides into families, giving the secretin family, as an example, with its members, secretin glucagon, GLPs, GIP, VIP, PHI, GHRH, PECAT. Also list other families.
Acknowledge the complexity due to receptor subtype multiplicity and cell-specific expression patterns. Provide concrete examples from Table 28-2 and their clinical relevance. Somatostatin. Produced by D cells, inhibits GI secretion, motility, splanchnic perfusion. Its analog, octreotide, is used for neuroendocrine tumors, example, carcinoid syndrome, post-gastrectomy dumping syndrome, enterocutaneous fistulas, and the initial treatment of acute hemorrhage due to esophageal varices. Secretin, produced by S cells, stimulates exocrine pancreatic and intestinal secretion. The gastrin secretory response to secretin administration forms the basis for the standard test used to establish the diagnosis of Zollinger-Ellison syndrome, cholecystokinin, CCK. Produced by M cells, stimulates pancreatic exocrine secretion, gallbladder emptying, inhibits sphincter of Oddi contraction, used in evaluations of gallbladder ejection fraction. Motilin, produced by M cells, stimulates intestinal motility. Peptide YY, produced by L cells, inhibits intestinal motilial proliferation. Highlight its importance as a specific and potent intestinotrophic hormone, currently under clinical evaluation as an intestinotrophic agent in patients suffering from the short bowel syndrome, unquote. Neurotensin. Produced by N cells, stimulates pancreatic and biliary secretion, inhibits small bowel motility, stimulates intestinal mucosal growth, intestinal adaptation. The gut's remarkable resilience.
Introduce the small intestine's capacity to adapt in response to varying demands imposed by physiologic and pathologic conditions, especially post-resection intestinal adaptation after massive small bowel resection.
Describe the process observed in animal models. Within a few hours after bowel resection, the remnant small intestine displays evidence of epithelial cellular hyperplasia. With additional time, villi lengthen, intestinal absorptive surface area increases, and digestive and absorptive functions improve.
Connect to humans. Post-resection intestinal adaptation in human patients is less well studied, but it seems to follow similar steps as that seen in experimental models, and it takes 1 to 2 years to complete.
Discuss the ongoing investigation into mechanisms, including specific nutrients, fiber, fatty acids, triglycerides, glutamine, polyamines, lectins, peptide hormones and growth factors, pancreatic secretions, and some cytokines. Explain how this adaptation serves to compensate for the function of intestine that has been resected. Note that jejunal reception is generally better tolerated, as ileum shows better capacity to compensate.
Conclude on the limitation. The magnitude of this response is limited. If enough small intestine is resected, a devastating condition known as the short bowel syndrome results, which we'll discuss later.
Small bowel disorders, challenges and solutions. Small bowel obstruction, SBO, a common surgical dilemma.
Let's begin this segment by tackling one of the most common and clinically critical surgical issues affecting the small intestine, small bowel obstruction, or SBO. This condition is, in fact, the most frequently encountered surgical disorder of the small intestine. Its prevalence and potential for severe complications make a thorough understanding of SBO absolutely paramount for anyone involved in medical care.
So what precisely causes an SBO? The etiologies are remarkably diverse, but they can be logically categorized based on their anatomical relationship to the intestinal wall, which helps clinicians pinpoint the problem. First, you can have intraluminal obstructions, where the blockage stems from something located inside the bowel lumen itself. Common examples include ingested foreign bodies, gallstones that have eroded into the bowel, or in newborns, thick meconium. Second, there are intramural obstructions, where the pathology originates within the wall of the intestine. This category often includes primary tumors of the small bowel or the inflammatory strictures that are characteristic of Crohn's disease, which we just discussed. And finally, the most prevalent type are extrinsic obstructions caused by something outside the bowel lumen that is compressing it. The vast majority of these are due to adhesions, scar tissue from previous surgeries, but they can also result from hernias, where a loop of bowel gets trapped, or from widespread cancer that has spread within the abdominal cavity, a condition known as carcinomatosis.
It is absolutely vital to emphasize just how dominant a cause intra-abdominal adhesions are for SBO. Intra-abdominal adhesions related to prior abdominal surgery account for up to 75% of cases of small bowel obstruction. This is a truly staggering statistic, highlighting that a significant majority of these obstructions are a direct consequence of previous surgical interventions. We are talking about a considerable patient burden. Over 300,000 patients are estimated to undergo surgery to treat adhesion-induced small bowel obstruction in the United States annually. What's particularly concerning is that a comprehensive 20-year trend analysis has definitively documented no decrease in this rate during this period. This underscores that it remains an ongoing problem of this old disease, a persistent and costly challenge in modern surgery. In fact, small bowel resection and lysis of adhesions consistently rank among the top emergency surgeries performed, further emphasizing their clinical impact.
Beyond adhesions, other less prevalent but still clinically significant etiologies include hernias, which always demand a meticulous physical examination due to their potential to cause bowel strangulation. Malignant bowel obstruction is another cause, though it's important to differentiate. This is often due to extrinsic compression or invasion by advanced cancers originating from other organs, rather than being primary small bowel tumors themselves. And of course, Crohn's disease, which we just meticulously covered, can cause fibrotic strictures that progressively narrow the lumen and lead to obstruction. Interestingly, while congenital abnormalities capable of causing small bowel obstruction usually become evident during childhood, sometimes, remarkably, they can elude detection and are diagnosed for the first time in adult patients. Classic examples of such elusive congenital issues include intestinal malrotation, where the gut develops in an abnormal configuration, or midgut volvulus, where a segment of the bowel twists on itself, both of which can lead to acute or chronic obstructive symptoms later in life.
A rare but diagnostically important cause of proximal small bowel obstruction to be acutely aware of is superior mesenteric artery syndrome. This occurs when the third, or horizontal portion of the duodenum is compressed by the superior mesenteric artery as it crosses over it, particularly when the angle between the artery and the aorta is acutely narrowed. This condition should be considered in young aesthetic individuals who have chronic symptoms suggestive of proximal small bowel obstruction, especially those with significant weight loss. It's often a diagnosis of exclusion after more common causes have been ruled out, but its recognition can prevent unnecessary interventions. Pathophysiology.
So, what precisely transpires within the body when a small bowel obstruction occurs? The moment the blockage sets in, a cascading series of physiological events is initiated. The immediate consequence is that gas and fluid accumulate within the intestinal lumen proximal to the site of obstruction. This accumulation is the fundamental driver of the characteristic colicky abdominal pain, and surprisingly, the diarrhea that some experience even in the presence of complete bowel obstruction, as the intestine frantically struggles to propel contents past the blockage. The gas primarily originates from swallowed air, though a smaller portion is produced by bacterial fermentation within the intestine. The accumulating fluid consists of swallowed liquids and voluminous gastrointestinal secretions, as the obstruction paradoxically stimulates intestinal epithelial water secretion, further compounding the distension.
As this relentless accumulation of gas and fluid continues unabated, the bowel distends and intraluminal and intramural pressures rise. Initially, the intestine responds with increased, forceful contractions in an attempt to overcome the obstruction, which accounts for the hyperactive bowel sounds often heard early on. However, if the obstruction persists, this increased pressure eventually overwhelms the muscular efforts, and the intestinal motility is reduced with fewer contractions. A critical and concerning pathophysiological change occurs with prolonged obstruction. The luminal flora of the small bowel, which is usually sterile, changes, and a variety of organisms have been cultured from the contents. While its exact clinical significance is still being fully elucidated, translocation of these bacteria to regional lymph nodes has been demonstrated, indicating a breach of the intestinal barrier. The most dangerous point in this cascade is when the rising intramural pressure becomes so high that it compromises the intestinal blood supply. This leads to impaired intestinal microvascular perfusion, which quickly results in intestinal ischemia and ultimately necrosis. This critical and time-sensitive condition is precisely termed strangulated bowel obstruction, an absolute surgical emergency demanding immediate intervention.
It's vital for clinicians to differentiate the progression in cases of partial small bowel obstruction from complete obstruction. In a partial obstruction, only a portion of the intestinal lumen is occluded, allowing passage of some gas and fluid, albeit with difficulty. Consequently, the pathophysiologic events tend to occur more slowly than with complete small bowel obstruction, and development of strangulation is less likely. This often allows for a period of non-operative management. However, there's a particularly insidious and dangerous form of bowel obstruction known as closed-loop obstruction. This occurs when a segment of intestine is obstructed both proximally and distally, effectively sealing it off, as seen, for example, with a volvulus where the bowel twists on its mesenteric axis. In these dire cases, the accumulating gas and fluid are trapped and cannot escape either proximally or distally from the obstructed segment, leading to an extremely rapid rise in luminal pressure and a rapid progression to strangulation. The absence of an escape route means ischemia can set in much faster, making it a true emergency. Clinical presentation. The classic constellation of symptoms that characterize small bowel obstruction are colicky abdominal pain, nausea, vomiting, and obstipation, which refers to the inability to pass flatus or stool. It's important to note that the prominence of vomiting often correlates with the location of the obstruction. It is typically a more prominent symptom with proximal obstructions than distal. The character of the vomitus can also provide crucial clues. With bacterial overgrowth and a prolonged obstruction, the vomitus may become more feculent, suggesting a more established obstruction where colonic contents have refluxed. Explain that continued passage of flatus and or stool beyond 6 to 12 hours after onset of symptoms is characteristic of partial rather than complete obstruction.
On physical examination, specific signs aid in diagnosis and severity assessment. Abdominal distension is a common finding, often more pronounced if the site of obstruction is in the distal ileum, where a greater length of bowel can distend, and it may be absent if the site of obstruction is in the proximal small intestine. Auscultation of bowel sounds is also important. They may be hyperactive initially, characterized by high-pitched rushes as the bowel attempts to push against the obstruction. But in late stages of bowel obstruction, minimal bowel sounds may be heard, as the bowel becomes fatigued or ischemic. Laboratory findings reflect intravascular volume depletion and consist of hemoconcentration and electrolyte abnormalities, with mild leukocytosis being common.
Now, here's a critical point for every clinician and informed listener. Watch out for the urgent and ominous features of strangulated obstruction. These signs indicate impending or actual bowel ischemia and demand immediate action. The hallmark symptom is abdominal pain, often disproportionate to the degree of abdominal findings, meaning the patient reports excruciating pain, yet the abdominal examination may not show commensurate tenderness or rigidity, a strong red flag for intestinal ischemia. Other critical signs include tachycardia, an abnormally rapid heart rate, localized abdominal tenderness on palpation, fever marked leukocytosis, a significantly elevated white blood cell count, and acidosis. Stress that any of these findings should immediately alert the clinician to the possibility of strangulation and the unequivocal need for early surgical intervention. This is not a situation that allows for watchful waiting.
Diagnosis.
State the 4 crucial goals of diagnostic evaluation for SBO. A. Distinguish mechanical obstruction from ileus. B. Determine the etiology. C. Discriminate partial from complete. And D. Discriminate simple from strangulating. Highlight history, prior operations, abdominal disorders, and physical exam hernias.
Detail radiographic evaluation.
The abdominal series.
Triad of dilated small bowel loops, 3 centimeters in diameter, air fluid levels seen on upright films, and a paucity of air in the colon. Discuss sensitivity, 70 to 80%, and low specificity mimics ileus colon obstruction. Explain false negatives, proximal SBO, fluid-filled lumen, and closed loop. Despite limitations, remains important due to widespread availability and low cost.
CT scanning now. That's really changed the game, hasn't it?
It absolutely has. CT scanning is increasingly the imaging test of choice, ideally with oral contrast. High sensitivity, 80 to 90%, and specificity, 70 to 90%. Describe findings. Discrete transition zone with dilation of bowel proximally, decompression of bowel distally, intraluminal contrast that does not pass beyond the transition zone, and a colon containing little gas or fluid. Explain CT signs of closed loop obstruction.
U-shaped or C-shaped dilated bowel loop associated with a radial distribution of mesenteric vessels converging toward a torsion point, and strangulation, thickening of the bowel wall, pneumatosis intestinalis, air in the bowel wall, portal venous gas, mesenteric haziness, and poor uptake of intravenous contrast. Stress CT's global evaluation for etiology.
And what about that water-soluble contrast, like gastrographin? I hear that's used quite a bit now.
Yes, water-soluble oral contrast has crucial prognostic and therapeutic values. Contrast reaching the colon within 24 hours is predictive of non-surgical resolution, high sensitivity specificity. Meta-analyses show it reduces the need for surgery, odds ratio 0.44, length of stay by about 2 days, and time to resolution by about 28 hours without an increase in morbidity or mortality. So it helps decide who needs surgery and even speeds up recovery for those who don't.
But CT isn't perfect for every situation, right? Particularly the less severe cases.
Exactly. A key limitation of CT is its low sensitivity, 50%, in the detection of low-grade or partial small bowel obstruction. For these, other contrast exams might be needed. Small bowel series, small bowel follow-through. Contrast is swallowed or instilled. Abdominal radiographs are then taken serially. Use water-soluble contrast agents, such as gastrographin, if perforation possible. More labor-intensive, but greater sensitivity in the detection of luminal and mural etiologies of obstruction. Enteroclysis, 200 to 250 milliliters of barium, followed by 1 to 2 hours of solution of methylcellulose in water, is instilled into the proximal jejunum via a long nasoenteric catheter. This double contrast technique permits a better assessment of mucosal surface and detection of relatively small lesions. Note it's rarely performed in the acute setting, CT enteroclysis, superior to plain X-ray small bowel contrast studies. CT enteroclysis therapy.
Okay, so when we're treating SBO, what are the first steps?
The absolute priority is fluid resuscitation. Patients are often very dehydrated, so giving IV isotonic fluid is crucial. We usually place a bladder catheter to monitor urine output closely. Broad-spectrum antibiotics are generally indicated if we suspect bowel ischemia or if surgery is planned.
And then NG tube, that's standard too.
Yes. A nasogastric NG2 for gastric decompression is vital. It decreases nausea, distension, and the risk of vomiting and aspiration. Longer nasoenteric tubes are rarely used today because they have higher complication rates and haven't proven to be more effective.
Now, the management approach itself, that seems to have shifted quite a bit from the old days, right? The whole sun should never rise and set idea.
You're right, there's been a significant reassessment. While historically complete SBO meant prompt surgery to minimize strangulation risk, the challenge is that clinical signs and currently available laboratory tests lack sufficient sensitivity and specificity to reliably discriminate between patients with simple obstruction and those with strangulated obstruction prior to the onset of irreversible ischemia. The goal is still to operate before the onset of irreversible ischemia, but we now recognize that a non-operative approach is often feasible and safe initially, providing closed-loop obstruction is ruled out and there's no sign of ischemia.
So studies have actually backed this up, that you can manage some complete SBOs non-operatively.
Yes, several studies have. One key study found that among patients with CT-diagnosed high-grade complete SBO who didn't need immediate surgery, 66 patients were successfully managed non-operatively. So conservative therapy in the form of NG decompression and fluid resuscitation is now commonly recommended in the initial management of non-ischemic bowel obstruction. Success rates for partial SBO are high, around 65–81%. For complete SBO, if symptoms don't improve within about 48 hours, then surgery is generally considered. A large study even showed that a 2-day limit of watchful waiting before surgery is not associated with an increase in mortality or postoperative morbidity, although costs might be higher.
And this is where that water-soluble contrast pathway comes in again, helping to make that decision.
Exactly. As we discussed, using water-soluble contrast helps predict who will resolve without surgery and actually speeds up resolution. It's become a key part of many management pathways, guiding decisions about when to proceed with feeding versus when to consider surgery, generally within that 48–72 hour window if contrast hasn't progressed.
And if surgery is needed, what happens then?
The specific operative procedure varies according to the etiology of the obstruction. Adhesions are lysed, tumors resected, hernias repaired. Regardless, the affected intestine should be examined and non-viable bowels should be resected. We assess viability based on normal color, peristalsis, and marginal arterial pulsations. Sometimes Doppler or fluorescein dye is used, but often clinical judgment is key. If it's just a short segment of questionable viability in a stable patient, it's usually resected with primary anastomosis. But if a large proportion is borderline, we try to preserve it, often leaving it intact and doing a second look operation 24-48 hours later to make a final call.
What about laparoscopy for SBO? Is that common now?
It's increasingly frequent and successful. Studies show the laparoscopic approach is associated with significantly lower rates of overall complications, surgical site infections, and a shorter length of hospital stay, 4 versus 10 days. End quote. It's best suited for early cases of proximal small bowel obstruction that are likely due to a single adhesive band. Challenges include bowel distension and multiple adhesions, leading to a conversion rate to open surgery of about 17-33%. A major concern was iatrogenic bowel injury, but a pooled analysis showed the risk of bowel injury and reoperation were not different between the two procedures, although laparoscopic surgery often takes longer.
Outcomes. What are the typical outcomes after SBO surgery?
The perioperative mortality for non-strangulating SBO surgery is less than 5%, mainly in elderly patients with comorbidities. For strangulated obstruction, mortality is higher, highlighting the need for prompt intervention. Long-term prognosis really depends on the underlying cause. For patients managed conservatively for adhesive SBO, less than 20% will have a readmission over the subsequent 5 years. For those undergoing surgery for adhesive SBO, recurrence rates are around 13.5% at 5 years, and the risk of reoperation is about 5.8% at 5 years.
So recurrence is still a definite possibility even after surgery.
It is. And considering the frequency and variability of SBO, studies have shown that having a standard hospital-wide policy can really help improve care, reducing time to surgery and shortening hospital stays. Standardization matters. Prevention.
Given how common adhesive SBO is, what about prevention? That seems crucial.
Absolutely. Preventing postoperative adhesions is a major focus. Good surgical technique, careful handling of tissue, and minimal use and exposure of peritoneum to foreign bodies forms the cornerstone, but it's often not enough. High readmission rates after colorectal or pelvic surgery, over 30% in 10 years for adhesive SBO, really underscore the problem.
So laparoscopy helps here too.
Definitely. Use of laparoscopic surgery when possible is strongly promoted. A large study showed open surgery is associated with a 4-fold increase in risk of small bowel obstruction within 5 years. For open surgery, the only therapy that has shown some success has been the use of hyaluronan-based agents, such as Sparafilm. These reduce adhesions, but their effect on reducing actual SBO incidence is less well defined. Also, wrapping of an intestinal anastomosis with the material may be associated with increased leak rates and is generally discouraged. Other causes of small bowel obstruction.
What about obstruction that happens right after surgery, early postoperative bowel obstruction?
Right, that occurs within 30 days of surgery, in about 0.7% to 9% of patients, more often after pelvic surgery. Diagnosis usually needs CT or a small bowel series. These obstructions are usually partial and only rarely is associated with strangulation. So the approach is often a period of extended non-operative therapy, 2 to 3 weeks, consisting of bowel rest, hydration, and TPN administration. But if it's a complete obstruction or there are signs of peritonitis, expeditious reoperation should be undertaken without delay.
And malignant SBO, that sounds particularly challenging.
It can be. It often indicates advanced disease with poor prognosis. But critically, 25% to 33% of patients with a history of cancer who present with small bowel obstruction have adhesions as the etiology. So they shouldn't be denied appropriate therapy just based on their cancer history. Even if it is recurrent malignancy, palliative resection or bypass can be performed and can improve quality of life in select cases, allowing over 70% to reestablish oral intake in one series, although morbidity and mortality are high. For widespread carcinomatosis and multifocal obstruction, management must be tailored to an individual patient's prognosis and desires. Options might include bypass or even just a palliative gastrostomy tube for symptom relief from nausea and vomiting, ileus and other disorders of intestinal motility, when the gut slows down.
Okay, let's shift from physical blockages to problems with the gut's movement itself. We need to talk about ileus and chronic intestinal pseudoobstruction. How are they different?
Good distinction. Ileus is a temporary motility disorder that is reversed with time as the inciting factor is corrected. Think of it as the bowel being temporarily stunned or asleep. Chronic intestinal pseudoobstruction, on the other hand, comprises a spectrum of specific disorders associated with irreversible intestinal dysmotility, a more fundamental ongoing problem. Ileus is a huge issue, a major cause of morbidity in hospitalized patients. Prolonged postoperative ileus alone costs $750 million and $1 billion annually in the United States, and is often the main reason for delayed hospital discharge after abdominal surgery. Pathophysiology.
What kinds of things can cause ileus?
Numerous factors can impair motility. The most common are abdominal operations, infection and inflammation like sepsis or peritonitis, electrolyte abnormalities, especially low potassium or magnesium, and drugs, particularly opiates and anticholinergics. For postoperative ileus, the proposed mechanisms include surgical stress-induced sympathetic reflexes, release of inflammatory mediators, and side effects of anesthetics and analgesics.
And how long does it normally take for motility to return after surgery?
There's a typical sequence. Small intestinal motility returning to normal within the first 24 hours, gastric by 48 hours, and colonic motility returning to normal by 2 to 5 days. This means listening for bowel sounds is not a reliable indicator that ileus is fully resolved, as the small bowel wakes up first. Functional evidence in the form of passing flatus or bowel movement is a more useful indicator. Resolution can be delayed by things like abscesses or electrolyte problems. Chronic intestinal pseudo-obstruction is different. It's caused by a large number of specific abnormalities affecting intestinal smooth muscle, the myenteric plexus, or the extraintestinal nervous system. These include visceral myopathies, muscle degeneration, and visceral neuropathies, nerve plexus degeneration, both sporadic and familial. Systemic disorders like scleroderma, muscular dystrophies, or Parkinson's can also cause it, as can certain viral infections like CMV or Epstein-Barr. Clinical presentation.
How does ileus typically present? Does it look like an obstruction?
Yes. The presentation resembles that of small bowel obstruction. Symptoms include inability to tolerate liquids and solids by mouth, nausea, and lack of flatus or bowel movements. Vomiting and distension can occur. The key difference often lies in the bowel sounds. Usually diminished or absent in ileus, contrasting with the hyperactive bowel sounds often heard in mechanical SBO. Chronic pseudo-obstruction presents with variable degrees of nausea and vomiting and abdominal pain and distension, reflecting that ongoing motility problem. Diagnosis.
Do we need to diagnose routine postoperative ileus?
No. Routine post-op ileus should be expected and requires no diagnostic evaluation. But prolonged postoperative ileus, typically defined as persisting beyond day 4 post-op, with symptoms like nausea, inability to eat, lack of flatus, and distension, occurs in 10% to 15% of patients undergoing intestinal surgery and does warrant investigation. Evaluation involves looking for specific factors, reviewing medication lists for opiates, checking electrolytes. Plain x-rays are often done but can be hard to distinguish from SBO. In the post-op setting, CT scanning is the test of choice to rule out an abscess or mechanical obstruction.
For chronic pseudo-obstruction, the diagnosis is suggested by clinical features and confirmed by radiographic and manometric studies. Sometimes, diagnostic laparotomy or laparoscopy with full-thickness biopsy might be needed to pinpoint the underlying cause, especially if a neural disorder is suspected. Therapy.
Management of ileus involves limiting oral intake and correcting the underlying inciting factor. An NG tube can help with decompression if needed. 5V fluids are crucial. If it's prolonged, TPN may be required.
Are there ways to reduce how long postoperative ileus lasts? It seems like a big deal.
Yes, many strategies have been tested. These include using NSAIDs like ketorolac, reducing opioid use, using perioperative thoracic epidural anesthesia with local anesthetics, though this doesn't always shorten a hospital stay, limiting 5E fluids, and importantly, early postoperative feeding after GI surgery, which is generally well tolerated and can reduce ileus in hospital stay. These are often bundled into ERIs, early recovery after surgery pathways. Multimodal approaches with 15-20 steps aimed at speeding recovery, many targeting ileus reduction.
What about medications? Prokinetic agents?
Traditional prokinetics have generally had unfavorable efficacy-toxicity profiles. However, a newer agent, alvamopam, a novel peripherally active mu-opioid receptor antagonist, has shown clear benefit. It's been proven in multiple trials to reduce duration of postoperative ileus, hospital stay, and rate of readmissions after certain bowel surgeries, though there's some debate about its cost-effectiveness outside clinical trials. For chronic intestinal pseudo-obstruction, therapy focuses on palliation of symptoms and nutritional management. Critically, surgery should be avoided if possible. No standard therapies are curative. Prokinetics like metoclopramide and erythromycin have poor efficacy. Cisapride is restricted due to cardiac toxicity.
So what are the options for severe cases?
For refractory disease, it might mean strict limitation of oral intake and long-term TPN. If severe pain or copious secretions persist, patients may require decompressive gastrostomy or an extended small bowel resection. Small intestinal transplantation has been applied with increasing frequency, but its ultimate role remains to be defined. Crohn's disease, a chronic inflammatory journey.
Let's now delve into the complexities of Crohn's disease, a chronic inflammatory bowel disease that represents a significant clinical challenge. It is precisely defined as a chronic idiopathic transmural inflammatory disease with skip lesions that may affect any part of the alimentary tract, although there is propensity to affect the distal small bowel. The term idiopathic means its cause is unknown. Transmural is a key pathological feature, indicating that the inflammation extends through the entire thickness of the bowel wall, from the inner lining to the outer serosa. And skip lesions is another hallmark, meaning there are areas of inflammation interspersed with healthy, unaffected segments of bowel, unlike the continuous inflammation seen in ulcerative colitis. Epidemiology and risk factors.
In terms of its prevalence and distribution, nearly 80% of patients with Crohn's disease have small bowel involvement, a significant majority, and within that group, 30% having terminal ileus exclusively, meaning their disease is confined to the very end of the small intestine. Recent U.S. prevalence, about 241 cases per 100,000. Globally, rates have been increasing, with the highest incidences reported in Western nations and those in northern latitudes, with Canada having the highest reported rates. Interestingly, in countries like China, prevalence is substantially below the West, but rates are rapidly increasing recently. There's also a significant ethnic variation observed. Members of Eastern European Ashkenazi Jewish population are at a 2- to 4-fold higher risk.
Gender-wise, most studies suggest that Crohn's disease is slightly more prevalent in females than in males, and the age at diagnosis often follows a bimodal distribution. Mean age falls in the 3rd decade of life years, with a second smaller peak in the 6th decade, though it can manifest at any age.
Both genetic predisposition and environmental factors are profoundly implicated. Genetically, the relative risk among first-degree relatives is 14 to 15 times higher, with about 20% reporting a family history. The concordance rate among monozygotic twins is as high as 67%, but it's not associated with simple Mendelian inheritance patterns. While families often have either UC or Crohn's exclusively, mixed kindreds also occur, suggesting some shared genetic traits.
Environmentally, higher socioeconomic status is associated with an increased risk. Most studies have found breastfeeding to be protective. And, critically, smoking. Crohn's disease is more prevalent among smokers, and smoking increases risk for both the need for surgery and the risk of relapse after surgery. Smoking cessation is crucial. Pathophysiology.
At its core, Crohn's disease is characterized by sustained inflammation. The fundamental question remains whether this inflammation represents an appropriate response to a yet unrecognized pathogen or an inappropriate response to a normally innocuous stimulus is unknown. No conclusive evidence supports a specific infectious agent. Animal models suggest in a genetically susceptible host, a non-pathogenic gut microbiome is sufficient to induce a chronic inflammatory response resembling that associated with Crohn's disease. This is hypothesized to result from either abnormal epithelial barrier function or immune dysregulation.
And the genetics are becoming clearer, right? Like the NOD2 gene.
Exactly. Specific genetic defects associated with Crohn's disease are beginning to be defined. The NOD2 gene on chromosome 16, the so-called IBD1 locus, is strongly linked. Persons with allelic variants on both chromosomes have a 40-fold relative risk. This is biologically plausible, as NOD2 mediates the innate immune response to microbes. Other putative IBD loci are also under investigation.
What about the link with appendectomy?
That's interesting. While appendectomy lowers UC risk, it was suspected to increase Crohn's risk. However, a meta-analysis now suggests the observed increased risk may in fact reflect diagnostic difficulty in a group of patients with incipient Crohn's.
Oh, okay. What does Crohn's actually look like pathologically?
The pathological hallmark is focal transmural inflammation. The earliest lesion characteristic is the aphthous ulcer. Small superficial ulcers often over lymphoid aggregates. Granulomas are highly characteristic, present in up to 70% of intestinal specimens. These are non-case eating and can be found anywhere, even in normal-appearing tissue or lymph nodes.
And how does it progress?
Aphthysae can coalesce into larger, stellate-shaped ulcers. Fusion can create linear or serpiginous ulcers, and transverse coalescence gives that classic cobblestone appearance of the mucosa. With advanced disease, inflammation can be transmural. Serosal involvement leads to adhesions. Fibrosis causes strictures. Abscesses, fistulas, and rarely free perforation can occur. And remember those discontinuous portions of intestine, so-called skip lesions.
And that fat wrapping you see during surgery.
Right, that's a key intraoperative feature. It's the encroachment of mesenteric fat onto the serosal surface of the bowel. And it correlates well with the presence of underlying acute and chronic inflammation. Differentiating Crohn's from ulcerative colitis is crucial. Crohn's is often transmural and discontinuous, potentially sparing the rectum, while UC is typically limited to the mucosa submucosa, continuous, and affects the rectum. Though backwash ileus and UC can sometimes confuse things. Clinical presentation.
What are the typical symptoms someone with Crohn's might experience?
The most common are abdominal pain, diarrhea, and weight loss. But the clinical features are highly variable depending on location and severity. It can be misdiagnosed initially as IBS or celiac disease. Patients can be broadly classified as having A. fibrostenotic, B. fistulizing, or C. aggressive inflammatory disease, though there's overlap. Onset is often insidious with a waxing and waning course. Constitutional symptoms like weight loss, fever, or growth retardation in children can be prominent.
Where does it usually affect the GI tract?
The disease affects the small bowel in 80% of cases, and the colon alone in 20%. Most with small bowel disease have ileocecal disease. Isolated perineal and rectal disease occurs in 5–10%. Uncommon sites include the esophagus, stomach, and duodenum. And we can't forget the extraintestinal manifestations. About 1/4 of all patients will have an extraintestinal manifestation, and 1/4 of those will have more than one. They are more prevalent among patients with Crohn's disease than UC. Examples include dermatologic issues like erythema nodosum or pyoderma gangrenosum, rheumatologic problems like peripheral arthritis or ankylosing spondylitis, ocular inflammation like uveitis, hepatobiliary issues like gallstones or sclerosing cholangitis, urologic problems like kidney stones, and miscellaneous issues like blood clots or osteoporosis. Some correlate with bowel inflammation severity, like erythema nodosum, others don't, like pyoderma gangrenosum. Diagnosis.
How is Crohn's typically diagnosed then, given all this variability?
It's usually by endoscopic findings in a patient with a compatible clinical history. It should be considered in patients with specific symptoms like RLQ pain, chronic diarrhea, or findings like strictures, fistulas, or inflammation granulomas on histology. The differential diagnosis is broad, including UC, IBS, ischemia, cancer, lymphoma, and infectious enteritis. Specific infections that mimic Crohn's include Campylobacter, Yersinia, Salmonella typhi, Mycobacterium tuberculosis, and CMV.
So there's no single definitive test?
Correct. No single symptom, sign, or diagnostic test establishes the diagnosis. It's based on a complete assessment of the clinical presentation with confirmatory findings derived from radiographic, endoscopic, and in most cases, pathologic tests. Routine labs might show things like anemia, but they are non-diagnostic on their own.
What are the key diagnostic tools then? Colonoscopy with intubation of terminal ileum. This is the main diagnostic tool. It can reveal focal ulcerations adjacent to areas of normal appearing mucosa, a cobblestone appearance, and those characteristic skip areas, differentiating it from UC. Small bowel contrast exams, barium follow-through, CT enterography, or MR enterography help visualize strictures, ulcers, and fissures beyond the colonoscope's reach. CT scanning, useful for finding intra-abdominal abscesses and ruling out other conditions in acute settings. EGD, for upper GI tract involvement, capsule endoscopy, increasingly used for the difficult-to-image small bowel. Antibodies, Panacea and Asca, can help differentiate. Asca plus Panacea favors Crohn's, Asca plus favors UC, but their use is hampered by low test sensitivities. Stool tests. Fecal calprotectin or lactoferrin can indicate inflammation but aren't routine for diagnosis, and because symptoms can be subtle, diagnosis often takes time.
Yes, often a diagnosis of Crohn's is typically made only after symptoms have been present for several years. Acute presentations can also occur. Intraoperative discovery mimicking appendicitis, treat medically, remove appendix as cecum okay. Acute abdomen due to obstruction, abscess, or perforation. Or perianal abscessus fistulis as the first sign. Therapy.
Since there's no cure, what's the goal of treatment?
The goal is to palliate symptoms rather than to achieve cure. Medical therapy aims to induce and maintain remission, while surgery is for specific complications. Nutritional support is crucial for managing common malnutrition. Medical therapy.
How is medical therapy guided?
Disease activity is assessed using indices like CDAI or Harvey-Bradshaw, classifying it as mild, moderate, or severe. Mild-moderate is usually outpatient, severe, often inpatient. There are two main approaches: top-down, potent agents first, or step-up, less potent first. Antibiotics play an adjunctive role for infections, perineal disease, fistulas, or active colonic disease.
What are the main drug classes used? Oral 5-ASA, mesalamine. Role is somewhat controversial, but often recommended for mild small bowel Crohn's due to minimal toxicity. Glucocorticoids, oral white. Effective for inducing remission but not preventing relapse. Hazardous long-term use, so tapered. We identify steroid dependence, recurrence on tapering, and steroid resistant patients. Controlled allele-released budesonide has fewer systemic effects for ileocolonic disease. Thiopurine antimetabolites, azathioprine, 6-mercaptopurine. For severe disease, effective for inducing maintaining remission, steroid tapering may decrease relapse after resection. Need monitoring for side effects like bone marrow suppression, methotrexate, alternative if thiopurines fail, cyclosporine, little role, biologic therapies. This was the huge advance. Successful introduction of infliximab, Remicade, anti-TNF antibody, for remission and fistula closure. Other anti-TNF agents include adalimumab, Humira, and certolizumab pegol, Cimzia, generally similar efficacy. Used for resistant cases, steroid tapering. Contraindicated with ongoing septic processes. Newer agents like vedolizumab and TDO target gut-specific integrins. Perianal disease. Antibiotics, metronidazole, ciprofloxacin, first line. Long-term therapy often needed. Azathioprine for relapse. Fistulas also treated with infliximab. Perianal disease, surgical therapy. Has the need for surgery changed with these newer drugs?
Yes, the need has decreased steadily, but the risk is still significant. 16.3%, 33.3%, and 46.6% at 1, 5, and 10 years respectively. Surgery is generally reserved for patients whose disease is unresponsive to aggressive medical therapy or who develop complications.
What are the main reasons for surgery?
Failure of medical management, persistent symptoms, steroid dependence, medication complications, especially steroid side effects, growth retardation in children, 30%, and disease complications like intestinal obstruction, most common, abscesses, often drained percutaneously first, fistulas, only if symptomatic, hemorrhage, perforation, or cancer.
What if Crohn's is found during surgery for suspected appendicitis?
Treat medically. Don't resect the ileum unless absolutely necessary. Remove the appendix unless the cecum is inflamed.
For planned surgery, what's the approach?
Thorough intestinal exam for active disease, thick wall, narrow lumen, fat wrapping. Look for skip lesions, 20%. Note length of unevolved intestine. Preferred procedure. Segmental intestinal resection of grossly evident disease followed by primary anastomosis. Crucially, microscopic evidence of Crohn's disease at the resection margins does not compromise a safe anastomosis. Randomized trials showed no difference in recurrence with 2 centimeters as 12 centimeter margins or end-to-end versus side-to-side anastomosis.
What about stricturoplasty? That seems important for preserving bowel length.
Absolutely. Stricturoplasty is a crucial alternative for obstructing lesions, especially for patients with extensive disease and fibrotic strictures who may have undergone previous resection and are at risk for developing short bowel syndrome. It allows for preservation of intestinal surface area. The technique involves a longitudinal incision closed transversely, like Heineke-Mikulich for 12 centimeters, Finney for longer, side-to-side enteroenterostomy for very long ones, biopsy ulcerations, mark sites with clips. Recurrence rates are no different from those associated with segmental resection. Theoretical cancer risk exists, but data is limited. Contraindicated with abscesses, fistulas, or near a planned resection. Best for diffuse disease or when length preservation is vital.
Are bypass procedures ever done?
Yes, sometimes for intramesenteric abscesses, dense inflammatory masses, or duodenal strictures where resection or stricturoplasty is too risky.
And laparoscopy?
Laparoscopic surgery for Crohn's can be challenging due to inflammation, but studies confirm benefits. Less post-operative pain, shorter duration of ileus, and a shorter hospital stay, with similar rates of disease recurrence.
What are the complication rates after surgery?
Around 15–30%, mostly wound infections, abscesses, anastomotic leaks.
Like recurrence. Surgery isn't curative, right?
Yeah, correct. Surgery is not curative. Recurrence is common. Endoscopic, 70% in 1, 85% in 3 occur. Clinical, 60% in 5 or 94% in 15 year. Reoperation is needed in about 13 by 5 years, median 7 and 10 years. Smoking is a strong risk factor for disease recurrence. Intestinal fistulas, abnormal communications.
Let's move on to intestinal fistulas. What exactly are they?
A fistula is an abnormal communication between two epithelialized surfaces. We differentiate internal fistula, for example, enterocolonic, from external fistula, for example, enterocutaneous, rectovaginal. We also classify by output. Low output, 200 ml a day, now high output, 500 ml all day.
What usually causes that?
Over 80% represent iatrogenic complications, mainly from enterotomies or anastomotic dehiscences after surgery. Spontaneous fistulas usually result from Crohn's or cancer. Pathophysiology depends on the structures involved. Enteroenteric fistulas can cause malabsorption. Entrovesicular cause UTIs. Enterocutaneous cause skin irritation excoriation. High output proximal small intestine fistulas are particularly dangerous, leading to dehydration, electrolyte abnormalities, and malnutrition.
Can they close on their own? What prevents closure?
They can, but closure is often inhibited by factors summarized by the FREN mnemonic: foreign body, radiation enteritis, infection inflammation, epithelialization, neoplasm, distal obstruction, Other factors include poor nutrition, steroids, gastric duodenal site, and a short tract. Clinical presentation.
How do iatrogenic fistulas typically present after surgery?
Usually evident 5-10 days post-op. Fever, leukocytosis, prolonged ileus, abdominal tenderness, wound infection. Diagnosis becomes obvious with enteric drainage, often associated with intra-abdominal abscesses.
How are they diagnosed?
CT scanning following the administration of enteral contrast is the most useful initial test. Shows contrast leakage and any abscesses which should be drained percutaneously. If anatomy is unclear, a small bowel series or enteroclysis examination can be obtained to show origin and rule out distal obstruction. A fistulogram, contrast injected into the tract, may offer greater sensitivity if needed.
Therapy. How are they managed? Is there a sequence?
Yes, an orderly sequence of steps. Stabilization, fluids, nutrition, sepsis control, skin protection, investigation, define anatomy, decision, plan treatment, definitive management, usually surgery if needed, and rehabilitation.
What's a goal of non-surgical management?
To increase spontaneous closure. Nutrition and time are the key components. Most need TPN. Octreotide is a useful adjunct for high-output fistulas, reduces hospital stay, time to closure, but not closure rates. Negative pressure wound therapy can help manage output and promote closure. 46% spontaneous closure in one study.
How long do you wait before considering surgery?
Most surgeons would pursue 2 to 3 months of conservative therapy. Rationale. 90% of fistulas that are going to close do so within 5 weeks, and that surgical intervention after this period is associated with better outcomes and lower morbidity. Patience is key.
And if surgery is needed?
Resect the tract plus segment of origin. Simple closure has high recurrence. It can be difficult due to extensive and dense intra-abdominal adhesions. Alternative therapies like biologic sealants are still being investigated. Outcomes.
What percentage close spontaneously?
Over 50% of intestinal fistulas close spontaneously, if those friend factors aren't present.
What are the outcomes of surgical repair?
A large retrospective review showed most were small bowel, iatrogenic, in patients with 5 prior surgeries. Operative repair had 4% 30-day mortality, 15% 1-year mortality, and 80% morbidity. First attempt was successful, 70%. Overall closure, 84%. Some needed 3 attempts. Closing the fascia was important. Another study found 30% recurrence linked to high output and non-resection surgery. Small bowel neoplasms, the rare and challenging cancers.
Let's talk about small bowel neoplasms, both benign, adenomas, fibromas, lipomas, etc., and malignant, adenocarcinomas, carcinoids, lymphomas, sarcomas, GI6. Why are these particularly challenging?
A key reason is that the majority of small bowel tumors are asymptomatic until late. The most common benign type, adenomas, are often found incidentally during EGD, especially the duodenum. Primary small bowel cancers are rare, but have been increasing in incidence, around 10,000 cases in 2017 U.S. Adenocarcinomas are most common, 35 to 50%, followed by carcinoids, 20-40%, lymphomas, 10 to 15%, and GISTs, 10 to 15%. GISTs are the most common mesenchymal tumors. The small intestine is also a frequent site for metastases, especially melanoma.
Who typically gets these? Are there risk factors?
Most patients are in their 5th or 6th decade of life. Risk factors include red meat, smoke-cured foods, Crohn's, celiac sprue, and genetic syndromes like HNPCC, FAP, and Peutz-Jeghers.
Pathophysiology.
It's strange they're so rare given the small intestine's huge surface area, right? Exactly. It's 90% of GI mucosal surface area, but only 1-2.4% of GI malignancies. Proposed explanations include dilution of carcinogens, rapid transit, low bacterial concentration carcinogenic products, mucosal protection, IgA hydrolases, and efficient apoptosis removing mutated cells.
What do we know about how adenocarcinomas develop?
They likely arise from adenomas via sequential genetic abnormalities, similar to colorectal cancer. Histologically, they can be tubular, villous, or tubulovillous. Malignant degeneration has been reported to be present in up to 45% of villous adenomas, which are often large and sessile, especially in the duodenum. The FAP connection is crucial. Patients have a nearly 100% cumulative lifetime risk of developing duodenal adenomas and a 100-fold greater risk of duodenal cancer. It's a leading cause of cancer death in colectomized FAP patients. Peutz-Jeghers syndrome involves hamartomatous polyps that can have adenomatous foci with malignant potential.
And GISTs, what's their defining feature?
The defining feature is a gain-of-function mutation of proto-oncogene KIT, a receptor tyrosine kinase. This leads to a constitutively activated KIT protein, driving persistent growth signals. The interstitial cells of Cachal, which normally express KIT, are implicated as the cell of origin. Staining for CD117, part of KIT, is key for diagnosis, positive in 95% of GISTs. Clinical presentation. Most neoplasms are asymptomatic until large. The most common presentation is partial SBO, crampy pain, distension, nausea, vomiting, from the tumor itself or intussusception. Second most common is indolent hemorrhage, leading to anemia.
What about physical exam in specific tumor types?
Exam often unrevealing or maybe a palpable mass, SBO signs, positive fecal occult blood, advanced disease, jaundice, cachexia, hepatomegaly, ascites by tumor type. Adenocarcinomas, adenomas, most common in duodenum except Crohn's-ileum. Periampullary location, obstructive jaundice pancreatitis. Duodenal, diagnosed earlier than jejunal. Carcinoid tumors, usually diagnosed after metastatic disease, liver, more aggressive than appendiceal. Carcinoid syndrome, diarrhea, flushing, etc. in 25-50% with liver mets. Rare without liver mets due to first-pass metabolism. Lymphoma, primary or systemic, most common in ileum. Partial SBO, most common presentation, with 10% present with perforation of GI sites. Second most common site after stomach, 25-35%, no regional variation. Greater propensity for overhemorrhage, metastatic tumors, obstruction, bleeding, metastatic tumors, diagnosis.
How are they usually diagnosed if symptoms are vague?
Rarely diagnosed preoperatively. Labs are nonspecific, except elevated 5-HIAA, CGA for carcinoid, CEA for adenocarcinoma with liver mets low sensitivity. Contrast radiography, enterocolysis is test of choice, 90% sensitivity. Upper GI with small bowel follow-through lower, 30-44%. CT scanning, 70-80% detection, assesses mets. Bleeding localization, angiography, tagged RBC scans.
What about endoscopy?
EGD for duodenum, visualized. Biopsy, EUS for layers. Colonoscopy for distal ileum. Intraoperative enteroscopy for beyond standard reach. Capsule endoscopy and double balloon endoscopy for distal lesions. CT-MR enterography as non-invasive tests. PED scans for metabolic activity malignancy risk. Therapy.
How are benign tumors treated?
Symptomatic surgical resection or endoscopic removal. Duodenal tumors, most challenging. Biopsy, symptomatic adenoma removed. Small lesions, 1 centimeter, endoscopic polypectomy. Larger, 2 centimeters, often surgical. Transduodenal polypectomy, segmental resection. Periampullary may need pancreaticodenectomy, Whipple. EUS guides endoscopic versus surgical for 1-2 centimeter lesions. Endoscopic resection for benign periampullary adenomas has equivalent efficacy to surgery but with lower morbidity. Surveillance needed due to recurrence.
What about FAP patients with duodenal polyp?
An especially aggressive approach. Screening EGD in mid-teens. Endoscopic removal plus surveillance. If surgery needed, pancreaticoduodenectomy is generally necessary due to multiple sessile nature and high recurrence with local resections. Rationale for standard Whipple, not pylorus preserving, due to remnant recurrence. Continued surveillance vital. Most duodenal carcinomas also need Whipple, except maybe third, fourth portion. And for malignancies in the jejunum or ileum, wide local resection of the intestine harboring the lesion. For adenocarcinomas, includes regional lymphadenectomy, locally advanced metastatic, palliative resection or bypass. Chemotherapy, no proven efficacy for adenocarcinomas.
How are carcinoid tumors managed?
Resection of all visible disease. Localized, segmental resection plus regional lymphadenectomy. Nodal mets risk increases with size, 3 centimeters, 75-90%. Check entire small bowel for multiple tumors, 30%. Metastatic disease, tumor diploting for survival and symptom control. Chemo has response rates but unclear impact. Octreotide is the most effective pharmacologic agent for management of symptoms of carcinoid syndrome. What about lymphoma? Ingiests, localized lymphoma, segmental resection plus mesentery, diffusus, chemoprimary, adjuvant chemo controversial, segmental resection, avoid wide lymphadenectomy, rarely mets, resistant to conventional chemo. Imatinib, Gleevec, tyrosine kinase inhibitor targeting kit is key for metastatic disease. 80% clinical benefit, 50-60% tumor reduction. Promising as a neoadjuvant adjuvant, sunitinib for resistance.
And metastatic cancers to the small bowel.
Symptomatic palliative resection bypass. Systemic therapy if effective chemo exists for the primary cancer. Outcome.
Survival rates?
Duodenal adenocarcinomas, complete resection. 5-year survival, 50-60%. Jejunal leo, 20-30%. Localized carcinoid, 75-95%. With liver metastases, 19-54%.
Intestinal lymphoma overall, 20-40%. Localized surgical, 60%.
GISTs, 35% recurrence. 5-year survival, 35-60%. Prognosis linked to tumor size and mitotic index, low grade, 5 centimeters, excellent prognosis. Radiation enteritis, the unintended consequence.
Let's move to radiation enteritis, an undesired side effect of radiation therapy for abdominal pelvic cancers. It manifests as 2 syndromes, right?
Yes, acute transient 75% patients and chronic inexorable 5-15% patients. Pathophysiology.
How does radiation cause this damage?
Radiation induces cellular injury directly and through the generation of free radicals. The principal mechanism is believed to be apoptosis, resulting from free radical-induced breaks in double-stranded DNA. The small intestine is highly susceptible due to its rapidly proliferating cells, especially the crypt stem cells.
What does the acute injury look like pathologically?
Villus blunting and a dense infiltrate of leukocytes and plasma cells within the crypts. Severe cases show mucosal sloughing, ulceration, hemorrhage. Intensity related to dose, 4,500 CGI. Risk factors for acute injury. Conditions limiting splanchnic perfusion, hypertension, diabetes, CAD, restricted intestinal mobility, adhesions, potentiated by chemotherapeutic radiation sensitizers. Acute usually resolves due to epithelial regeneration.
But chronic is different, more severe.
Yes. Chronic radiation enteritis involves a progressive occlusive vasculitis leading to chronic ischemia and fibrosis that affects all layers of the intestinal wall. These changes cause strictures, abscesses, and fistulas. Clinical presentation:
Symptoms:
acute, nausea, vomiting, diarrhea, crampy abdominal pain. Transient, diagnosis usually obvious. CT if peritonitis signs. Chronic, evident within 2 years usually, months to decade. Diarrhea or partial SBO, nausea, vomiting, distension, pain, weight loss. Terminal ileum most frequently affected. Other, complete obstruction, hemorrhage, abscess, fistula. Diagnosis:
how is chronic radiation enteritis diagnosed?
review radiation records, dose, fractionation volume,
Yeah.
lesions localized to high dose areas, enterocolysis, most accurate imaging test, 90% sense back, CT scan, not sensitive specific, but used to rule out recurrent cancer. Therapy:
How is acute treated?
self-limited, supportive therapy, antiemetics, antidiarrheals,
Yeah.
hospitalization to IV fluids for dehydration, rarely needs radiation reduction
That's
station.
chronic. That
Yeah.
sounds tough.
It's a formidable challenge. Antidiarrheals, low residue diet for obstructive symptoms. Surgery is difficult, is associated with high morbidity rates, and should be avoided in the absence of specific indications. High-grade obstruction, perforation, hemorrhage, abscesses, fistulas.
What's the goal of surgery as needed?
Limited resection of diseased intestine with primary anastomosis between healthy bowel segments. Challenges: diffuse nature of fibrosis and dense adhesions, difficult to distinguish between normal and irradiated intestine intraoperatively. Critically, anastomosis between the irradiated segments have been associated with leak rates as high as 50%. If limited resection not possible, intestinal bypass, except for hemorrhage. Sometimes extensive resections leading to short bowel syndrome are unavoidable. Outcomes: acute severity doesn't predict chronic development. Surgery for chronic has high morbidity, 10% mortality. Prevention:
How can this be prevented?
keep radiation exposure 5,000 CG if possible. Multi-beam techniques, tilt tables, oral sulfasalazine might help acute, some studies. For post-op radiation, surgical techniques like using an absorbable mesh sling can keep the small bowel out of the pelvis. Meckel's diverticula, the persistent embryonic remnant.
Let's talk about Meckel's diverticulum. What is it exactly?
It's the most prevalent congenital anomaly of the gastrointestinal tract, affecting approximately 2% of the general population. It's a true diverticulum, contains all layers, location, usually found in the ileum within 100 centimeters of the ileocecal valve.
And that heterotopic mucosa is key, right?
Absolutely. Found in 60% of diverticuli, and 60% of which is gastric mucosa, others pancreatic Caccini, Brunner's glands, etc. And the rule of twos: 2% prevalence, 2.1 male predominance, location 2 feet proximal to the ileocecal valve in adults, and half of those who are symptomatic are under 2 years of age. Just a rough guide, though. Pathophysiology:
How does it form?
incomplete vitelline duct obliteration during the 8th week gestation, also related. Omphalomysenteric fistula, enterocyst, fibrous band. Sometimes a remnant of the left vitelline artery forms a mesodiverticular band.
How do complications arise? Bleeding, obstruction.
Bleeding is usually from ileal mucosal ulceration that occurs adjacent to acid-producing heterotopic gastric mucosa. Obstruction mechanisms: 1. Volvulus of the intestine around the fibrous band. 2. Entrapment of intestine by a mesodiverticular band. 3. Intussusception with the diverticulum acting as a lead point. 4. Stricture secondary to chronic diverticulitis. Also, Litter's hernia, Meckel's and hernia sacs, can cause obstruction. Clinical presentation:
Are they usually symptomatic?
no asymptomatic unless complications occur. Lifetime incidence 4 to 6%. And the belief that risk decreases with age has been challenged.
What are the common presentations when they are symptomatic?
Bleeding, intestinal obstruction, diverticulitis. Bleeding, most common in children, 50% complications 18, rare 30. Obstruction, most common in adults. Diverticulitis, 20% symptomatic, mimics appendicitis. Neoplasms, 0.53, 0.2% symptomatic, mostly carcinoid, are rare. Diagnosis:
How are they usually found?
most discovered incidentally. Rarely diagnosed pre-op without bleeding. Imaging is tough. CT has low sensitivity. Enterocolysis, 75% accuracy, but not for acute cases. Radionuclide scans, 99 MTC per technetate, are helpful only when the diverticulum contains associated ectopic gastric mucosa, with high accuracy in kids, 90%, but low in adults, 50%. Angiography can localize acute hemorrhage. Therapy,
How are symptomatic ones treated?
diverticulectomy with removal of associated bands. If bleeding, segmental resection of ileum that includes both the diverticulum and the adjacent ileopeptic ulcer. Also resect for tumor or inflamed perforated base.
What about finding one incidentally? That seems controversial.
Very controversial. Past thinking. Against prophylactic removal, high number needed to treat to prevent one death. Current. More enthusiasm due to a minimal morbidity of removal and possible underestimation of complication risk. Many advocate a selective approach where move in patients 50 years or of 2 centimeters, but importantly, no controlled data supporting or refuting these recommendations exist. Acquired diverticula, false pockets of the gut.
Now, what about acquired diverticula? How are they different?
These are designated false diverticuli, mucosa and submucosa herniate through muscle, lack complete muscularis.
Yeah.
Common in duodenum, periampullary, juxtapapillary, and periviterian. 75% juxtapapillary on medial wall. Jejunal diverticuli also occur. 80% jejunum, 15% epimelium, 5% both. Jejunal, large, multiple, ileal, small, solitary.
How common are these?
Duodenal prevalence varies widely, 0.16, 27%, rare 40, mean diagnosis 56, 76. Jejunally affect 1 to 5%, increasing with age, 6th, 7th decades. Pathophysiology,
How do these form?
hypothesized pathogenesis, acquired abnormalities of intestinal, smooth muscle, or dysregulated motility, leading to herniation of mucosa and submucosa through weakened areas of muscularis, often where blood vessels penetrate.
What complications can they cause?
Bacterial overgrowth, B12 deficiency, anemia, malabsorption, steatorrhea. Periampullary duodenal can become distended with intraliminal debris, causing common bile duct pancreatic duct compression, obstructive jaundice pancreatitis. Jejunal can cause obstruction to susception compression. Clinical presentation.
Are they usually symptomatic?
No, asymptomatic unless complications arise, 6-10%. Complications include obstruction, diverticulitis, hemorrhage, perforation, malabsorption.
Periampullary.
Duodenal symptoms might include choledocholithesis, cholangitis, recurrent pancreatitis, sphincter ovati dysfunction, but a clear link, not been demonstrated. Jejunal symptoms like intermittent pain, flatulence, diarrhea, constipation reported 10-30%, but relationship similarly unclear.
Diagnosis.
Most discovered incidentally. Can be mistaken for pseudocysts, biliary cysts, neoplasms on ultrasound CT, can be missed on endoscopy, best diagnosed on upper gastrointestinal radiographs. Enterocolysis, most sensitive test for detecting jejunal diverticuli. Theory, asymptomatic left alone. Bacterial overgrowth, antibiotics, other complications, bleeding, diverticulitis, segmental intestinal resection for jejunum, lateral duodenal diverticuli, bleeding obstruction, diverticulectomy, medial duodenal diverticuli, penetrate pancreas, very challenging, non-operative if possible, endoscopy, emergent bleeding, lateral duodenotomy over sewing, perforation, wide drainage. Diverticulectomy for biliary pancreatic symptoms is controversial and not routinely recommended. Mesenteric ischemia, blood flow, and the gut.
Let's discuss mesenteric ischemia, problems with blood flow to the gut. 2 distinct syndromes, right? Acute and chronic.
Exactly. Acute mesenteric ischemia.
What causes the acute form?
4 main mechanisms. Arterial embolus, 50%, usually heart, often lodges in SMA. Arterial thrombosis at proximal arteries, usually on pre-existing atherosclerosis. Vasospasm, NOMI, often in critically ill on vasopressors. And venous thrombosis, 5 to 15%, usually SMA vein.
Outcome is rapid and severe. Mucosal sloughing within 3 hours. Full thickness, intestinal infarction by 6 hours.
Clinical presentation.
Hallmark is severe abdominal pain, out of proportion to the degree of tenderness on examination. Typically colicky mid-abdomen, nausea, vomiting, diarrhea. Physical findings often absent early. Infarction onset brings distension, peritonitis, bloody stools. Chronic mesenteric ischemia
How is chronic different?
develops insidiously, allowing for development of collateral circulation, rarely leading to infarction. Arterial form, atherosclerotic lesions in main splanchnic arteries, celiac, SMA, IMA. Most symptomatic have 2 arteries involved. Venous form, portal splenic veins involved may lead to portal hypertension, varices, splenomegaly, hypersplenism.
Clinical presentation.
Chronic arterial, postprandial abdominal pain leading to food fear and weight loss, often mistaken for malignancy. Chronic venous, often asymptomatic, collateral drainage. Incidental finding. Some may present with bleeding from varices.
Right. And the detailed diagnosis and management of these vascular issues are covered elsewhere in our source material.
Yeah.
But their impact on the small intestine is what we're focusing on here. Miscellaneous conditions. Unpacking the unexpected. Miscellaneous conditions.
Yeah.
Obscure GI bleeding.
What is obscure GI bleeding?
It's gastrointestinal bleeding for which no source has been identified by standard EGD colonoscopy. Can be overt, visible blood, or occult. Iron deficiency anemia, positive guaiac. Obscure bleeding is occult in 20% of cases.
Why is it so frustrating to diagnose?
Because most of the small bowel is beyond the reach of these examinations, and it contains most lesions responsible for obscure GI bleeding.
What causes it?
In adults, small intestinal angiodysplasias account for approximately 75%. Neoplasms account for approximately 10%. In children, Meckel's diverticulum is the most common etiology. Others: Crohn's, infections, NSAID ulcers, vasculitis, ischemia, varices, diverticulae, intussusception.
How is it evaluated?
Tailored to severity. Enteroscopy is playing an increasingly important role. Techniques include push enteroscopy. Reaches 60 centimeters of proximal jejunum, yield 3 to 65%, allows cauterization. Sonde enteroscopy, propelled by peristalsis, sees 50-75% mucosa, but lacks biopsy therapeutic capability. Has therefore been abandoned in favor of capsule endoscopy. Wireless capsule enteroscopy, excellent tool in the patient who is hemodynamically stable but continues to bleed. Success rates up to 90%. Higher diagnostic yield in contrast studies, but one study found this did not translate into an improvement in outcomes, similar rebleeding, etc.
Why didn't the better diagnostics lead to better outcome?
That's the continuing challenge. The inability to perform biopsies or carry out any therapeutic interventions of capsule endoscope likely prevents the improved diagnostic yield from translating into improved patient outcomes. You can see it, but you can't fix it or biopsy it with a capsule.
So what's the overall diagnostic approach?
If bleeding stopped, push or capsule enteroscopy first. If negative, maybe enterocolysis, low yield. If still no diagnosis, watch and wait is reasonable. Angiography, even without active bleeding, might show angiodysplasia. For persistent percurrent bleeding needing transfusions. Exploratory laparoscopy or laparotomy with intraoperative endoscopy. Endoscope inserted orally or via enterotomy, bowel telescoped over it. Transilluminated bowel should be examined externally with the operating room lights dimmed to spot angiodysplasias, mark lesions for resection. Examine during insertion to avoid misidentifying trauma. Small bowel perforation.
Small bowel perforation. Historically, this was often from peptic ulcer disease, right? But now...
Now, iatrogenic injury incurred during gastrointestinal endoscopy is the most common cause. Other causes: infections, TB, typhoid, CMV, Crohn's, ischemia, drugs, K+, NSAIDs, radiation, Meckel's acquired diverticulae, neoplasms, lymphoma, etc., foreign bodies.
Which endoscopic procedure is most common for perforation?
Duodenal perforation during endoscopic retrograde cholangiography, ERCP, with endoscopic sphincterotomy, ES, is the most common. 0.5% incidence. Stafford classification, type I to A4, helps guide management. Type 2, retroperitoneal duodenal, is most common and can often be managed non-surgically.
How is it diagnosed and treated?
Type 2 can mimic pancreatitis. CT scanning, most sensitive, pneumoperitoneum, retroperitoneal air, contrast extravasation, fluid. Note: up to 30% will have evidence of air in the retroperitoneum after ERCP, even if asymptomatic, needing no therapy. Therapy: type 2 can be managed non-operatively in the absence of progression and sepsis, intraperitoneal duodenal perforations, surgical repair with pyloric exclusion and gastrogenostomy or tube duodenostomy. Jejunal perforations, usually into peritoneum, cause overt symptoms. Plain X-rays may show free air. CT, if suspected, requires surgical repair or segmental resection. Trileukocytes.
What is chyleukocytes?
Accumulation of triglyceride-rich peritoneal fluid with a milky or creamy appearing. From intestinal lymph, coleus model in the peritoneal cavity. Chylomicrons cause the appearance.
What causes it?
Western world. Abdominal malignancies, cirrhosis, Eastern developing, infections like TB, filariasis, also post-op trauma, aortic surgery, lymph node dissection, IVC resection, liver transplant. Others: congenital lymphatic abnormalities, radiation, pancreatitis, right-sided heart failure.
Mechanisms.
3 proposed. A, exudation from dilated lymphatics due to obstruction. B, direct leakage through lymphoperitoneal fistula, trauma surgery. C, exudation through dilated retroperitoneal lymphatics, congenital thoracic duct obstruction.
Presentation.
Abdominal extension, weeks and months. Post-op can be acute, first week. or delayed adhesion.
Or diagnosis.
Paracentesis is the most important diagnostic test. Fluid triglyceride 110 mg/dL is diagnostic. CT for nose masses fluid.
Yep.
Lymphoscintigraphy for leak localization. Surgical planning. Little data on optimal management. Focus on underlying causes. Most respond to high protein and low fat diet supplemented with medium chain triglycerides.
Yeah.
MCTs absorbed via portal vein, don't form chylomicrons. Non-responders, fasted, PPN. Octreotide decreases lymph flow. Paracentesis for respiratory symptoms. 23 respond to conservative. 13 need surgery. Post-op trauma cases best managed surgically. Surgical repair for leaks. Limited resection if peripheral mesenteric extravasation. Peritoneovenous. Shunting for poor surgical candidates. High complications. Intussusception.
What is intussusception?
One segment of the intestine becomes drawn into the lumen of the distal segment. Pediatric versus adult presentation differs. Pediatric, usually ileocolic, idiopathic radiological reduction often works. Adult, far less common, and usually have a distinct pathologic lead point, which can be malignant in up to 1/2 of cases. Presentation. Intermittent abdominal pain, SBO signs.
Diagnosis and treatment.
CT scan of choice. Target sign. Treatment. Surgical resection of the involved segment and the lead point, with pathology. Note incidental target signs on CT without symptoms, likely normal peristalsis. Atypical form after Roux-en-Y gastric bypass, retrograde into susception, distal into proximal. Usually no lead point, maybe motility disorder. Surgical reductions without resection reported. Pneumatosis intestinalis.
What is pneumatosis intestinalis?
Presence of gas within the bowel wall. Most common jejunum. Not a disease, but a sign. Idiopathic or associated with other disorders. Pathogenesis unclear.
Why is it surgically important?
Its association with bowel ischemia and infarction, both of which necessitate emergent surgical intervention. Need full evaluation, close monitoring. Short bowel syndrome, SBS, living with less intestine.
Finally, short bowel syndrome, SBS. This sounds serious.
It is a devastating condition after intestinal resections performed for many of the diseases discussed in this chapter. Definition. Functional, significant malabsorption, or anatomical, arbitrarily 200 centimeters of residual small bowel in adult patients.
What usually leads to it in adults?
Acute mesenteric ischemia, malignancy, and Crohn's disease. 75% from single massive op, 25% cumulative from multiple ops, typical for pediatric causes. Atresias, volvulus, necrotizing enterocolitis. Prevalence, hard to estimate. Pathophysiology.
How much resection is too much?
Resection, 50% generally tolerated. Malabsorption, 50-80% resected. TPN dependence, likely if 100 centimeter residual, no colon, 60 centimeters, intact colon. Infants can sometimes wean with as little as 10 centimeters.
What factors predict weaning off TPN?
Several key factors. 1, intact colon, absorbs fluid electrolytes, short-chain fatty acids. 2, intact ileocecal valve. Delays transit, prolongs contact time, prevents bacterial overgrowth. 2, intact ileocecal valve. 3, healthy versus diseased residual small intestine. 2, intact ileocecal valve. 4, jejunal resection better tolerated than ileal. Liam needed for specific bile salt B12 absorption.
What about intestinal adaptation? Does the remaining bowel compensate?
Yes. Over 1-2 years post-resection, there's compensatory adaptation. Reduced bowel movements, increased enteral assimilation, reduced TPN needs. Some wean off TPN entirely. Mechanisms poorly understood. Malabsorption is often exacerbated by hypergastrinemia-associated gastric acid hypersecretion 1 to 2 years post-op, which inhibits absorption by inactivating enzymes. Therapy. Medical therapy.
What's the initial medical approach?
Manage the precipitating condition, aggressive fluid electrolyte repletion. Most need TPN initially. Gradual enteral nutrition. High-dose H2 antagonists, PPIs for gastric acid. Antimotility agents, loperamide diphenoxylate. Octreotide use is tricky. Reduces GI secretion but may inhibit adaptation.
What are the risks of long-term TPN?
Significant PPN-associated morbidities. Catheter sepsis, venous thrombosis, liver and kidney failure, and osteoporosis. Liver failure often leads to combined liver bowel transplant. Reduced life expectancy. 5-year survival, 50-75%. Non-transplant surgical therapy.
Are there surgical options besides transplant?
Restore intestinal continuity if possible. Other operations to improve absorption have unclear efficacy and/or substantial morbidities, not routinely applied. Goal is to slow transit or increase length. Slowing transit ops, segmental reversal, colon interposition, valves, pacing. Limited experience, lack objective evidence, often cause obstruction.
What about intestinal lengthening?
2 main types. LILT, longitudinal intestinal lengthening and tailoring, Bianchi 1980. Separates vasculature, longitudinal division, doubles length. Mostly for pediatric patients with dilated bowel. STEP, serial transverse enteroplasty. Lengthens dilated small intestine without the need for separating its dual vasculature. International registry showed 47% achieved enteral autonomy, median 21 months. Step serial transverse enteroplasty. Intestinal transplantation.
When is intestinal transplantation considered?
It's complex, increasingly performed, accepted indication. Life-threatening complications attributable to intestinal failure and/or long-term TPN therapy.
What specific complications trigger consideration?
A. Impending overt TPN-related liver failure. B. Thrombosis of major central veins compromising CPN access. C. Frequent catheter-related sepsis. D. Frequent severe dehydration despite medical management.
What types of transplants are done?
37% intestine alone, 30% intestine liver pancreas, 24% intestine liver. Indications vary for each type.
Outcomes.
Nearly 80% of survivors have full intestinal graft function with no need for TPN, but substantial morbidities. Acute or chronic rejection, CMV infection, post-transplant, lymphoproliferative disease, alternative therapies.
Any other therapies being explored?
Yes, pharmacologic biologic therapies to expand mucosal surface enhance absorption. GLP-2, glutamine plus growth hormone plus modified high-carb diet are under evaluation. Outcomes.
What percentage of SBS patients achieve TPN independence overall?
About 50-70%. Prognosis better for pediatric patients.
Survival data.
Limited. One study of 124 adults, non-malignant SBS, 2-year 86%, 5-year 45%, worse with end enterostomies or 50-centimeter residual. No randomized trials comparing transplant to chronic TPN. Graft survival rates reported. Intestine alone, 1-year 80%, 5-year 44%, 10-year 26%. Combined transplants show similar patterns. Outro.
Wow, what an absolutely incredible and deeply intricate journey we've taken through the small intestine. From its microscopic intricacies of villi and crypts to its remarkably diverse and profound roles in immunity, endocrinology, and of course the fundamental process of digestion, it truly stands as a master of life support and defense within us. It is unequivocally so much more than just a tube. So what does this profound deep dive, this mastery of intricate detail, truly mean for you, our dedicated listener?
This deep dive means you now possess a genuinely comprehensive and nuanced understanding of this vital organ. You've gained insights into its complex cellular physiology, its intricate developmental processes, and the broad spectrum of challenging conditions that can affect it. You are now equipped with the precise, detailed knowledge that elite professionals in this field meticulously value and utilize. This level of understanding allows for a much more informed perspective on not just gastrointestinal health and disease, but also on broader medical advancements and how our bodies truly function at a profoundly fundamental level. You've truly deepened your grasp of human biology.
Given the small intestine's profound and often underestimated capacity for adaptation and its central orchestrating role in immunity and hormone production, it makes you wonder what untapped potential might still lie hidden within this organ. How might a deeper understanding and strategic harnessing of its intricate functions lead to breakthroughs for treating a wider array of systemic diseases, extending far beyond just those directly affecting the gut itself? It truly challenges us to think differently about this seemingly familiar organ.
That's a truly powerful and forward-looking question, and it beautifully encapsulates the continuous evolution and thrilling frontier of medical science. We encourage you to carry this spirit of meticulous inquiry and mastery forward, continuing your own deep dives into the complex and fascinating world around us, armed with the precise, detailed information you've gained today.
Absolutely. Thank you for joining us on the deep dive. We look forward to having you back for more illuminating journeys into complex topics, pushing the boundaries of our knowledge.